भेजते नहीं है बिना बॉडीगार्ड।
अच्छा
लॉन्ग डिस्टेंस पे मैम को जाने नहीं देते बिना बॉडीगार्ड।
हाँ भेज देते हैं कि ले
इधर सबको हो गया।
हाँ ये सब हो गया।
प्लस थोड़ा सा गाइड
वहाँ पे पीछे में करवा
ड्राइवर सीधा
दीजिए।
रास्ता उसका नहीं समझता।
हो गया ना? ठीक। अब आ रहा है ना? क्या है? क्या बाबू? 115 pain you take it from here? Who you in your team?
हेलो पहुँच गए।
हम करते हैं।
खा लिए अरे खा लिए
पीछे लेके जाओ इसको यार ऊपर रखिए।
हेलो इधर बात करो जेबा है।
हेलो
हेलो प्रणाम मैम।
Check, check.
Already signed. म्यूट है ना? मेरे सामने तो नहीं है। Obstructive लगता है अल्ट्रासाउंड यहाँ से बंद करने से आवाज नहीं आ रहा। छोड़िए ना।
हेलो हेलो ठीक हेलो हेलो ठीक ठीक है
हेलो, इधर ले लीजिएगा।
Hello.
Hello, good morning everyone. Now we are going to start the program. So ladies and gentlemen, boys and girls, it is my honor to recognize the two dynamic ladies of our department who will be instrumental in driving us forward
From the inaugural session to the valedictory function.
First,
I invite
Dr. Talak Afroz, our first year PG, to join me on stage. Next, I request the pleasure of Dr. Seema Tabassu ma'am, who is the youngest professor of Bihar Government Medical Colleges, to also join us. Please join me in giving them a warm and well-deserved round of applause. सीमा तबस्सुम मैम के लिए मैं यही कहूंगा कि चांद हैरा है, सितारे भी परेशानी में है, ये अक्स किसका है जो इतनी रोशनी पानी में है. थैंक यू.
Thank you, Dr. G.S. Jaffer. A very good morning, Suprabhat and Khush Amdeed to all. It's my great pleasure to welcome you to the CME of Society of Clinical Anatomists, a gathering that embellished the spirit of continuous learning and professional development in the field of anatomy. As we embark on this journey of knowledge, innovation, and collaboration, we are reminded of the critical role that in our profession. Once again, from the depths of my heart, I welcome everyone in this journey of knowledge. मंजिल से आगे बढ़कर मंजिल तलाश कर, मंजिल से आगे बढ़कर मंजिल तलाश कर, मिल जाए तुझको दरिया तो समंदर तलाश कर. हर शीशा टूट जाता है पत्थर की चोट से, हर शीशा टूट जाता है पत्थर की चोट से, पत्थर ही टूट जाए वो शीशा तलाश कर. Over the next few hours, we have an exciting and diverse program lined up. We will hear from leading experts who will share their insights on cutting-edge researches and emerging trends. Our panel discussion will provide ample opportunities for interactive learning and exchange of ideas beneficial for the budding anatomist. Now I would like to invite our principal, sir, Professor Dr. K. N. Mishra, sir, Professor Rashmi Prasad, ma'am, Dr. Padamjeet Panchal, sir, our HOD, Dr. S.K. Kant, sir, our organizing secretary, Dr. G.S. Jha, and our co-organizing secretary, Dr. Archana Gautam, on the dais. I request all of you to please come on the stage. Dr. Professor Vinod Kumar, sir, kindly come here. Now, as we are about to commence the lighting of lamp ceremony, a tradition that symbolizes the dispelling of darkness and the ushering in of the knowledge, I would like to invite all the dignitaries on the dais to come forward for lighting of lamp. Please come, sir. Now, our organizing secretary, Dr. G.S. Jha, please come on the stage to continue the session.
Hello. We would like to felicitate the president of Soca, who is not over here, but he might be on the online platform. He is one of the humble doctor which I have ever seen in my life. He constantly talked to me on my WhatsApp till 1 p.m. yesterday night. But please do not send me any gift because it will be the wastage of the courier money. Have you ever heard of any doctors who will say you that do not send me because of the wastage of the courier? So he's one of the humble person, and he is the one who registered himself immediately after the confirmation of the Soca. So I've got the privilege to felicitate Dr. M. Shiv Kumar sir. I request Principal sir to please symbolically felicitate him so that we will meet him, we will hand over this memento and the chadar to Professor Dr. M. Shiv Kumar sir. Next, we would like to felicitate Professor Dr. M. Muthu Kumar sir, who is the Secretary of the Soca, and he is one of the finest editor which I have ever seen in my life. He edits even the comma and full stop, which I think it is very impossible for anyone to edit like that. So I request Dr. Rasmi ma'am to please felicitate Dr. M. Muthu Kumar sir. And now I will request Dr. Subodh sir to please come on the dais and felicitate Principal sir. Now I would like to request Dr. MC Burma sir and Dr. KK Misra sir to please come on the dais and felicitate our dynamic HOD, Dr. SK Karan sir. Now, right to request Dr. Seema Tabasu ma'am and Dr. Archana ma'am to please felicitate Dr. Poonam ma'am. Dr. Binod sir, Dr. Panchal sir, and Dr. Rasmi ma'am will be felicitated after the scientific session, since all of them are the chairperson of the scientific session. Now I hand over mic to Dr. Seema Tabasu.
Now I would like to invite our principal, sir, Professor. Now I request the scientific session chairpersons, Dr. Professor Vinod Kumar, sir, Professor Rashmi Prasad, ma'am, Dr. Padmjit Panchal, sir, to stay on the dais to chair the scientific session. वो उसका था ना, इसका था ना। हाँ तो इसको अच्छा ठीक तो आप बोलिए ना सर वहाँ ज्वाइन कर लेना अरे भाई हाँ अच्छा sorry, I handle the mic to the Talat Afroz, first year PG, to continue the session.
Thank you, ma'am. A very good morning to all. Respected delegates, HOD sir, my teachers, seniors, my dear colleagues and juniors. I myself, Dr. Talat Afroz, first year PG, welcomes with an immense pleasure in the CME of Society of the Clinical Anatomist. Now it's time for the special treat. We are delighted to invite Anju Kumari, Pari Kumari, Muskan Saha, Shreya Sinha, and Priyanshi Jha of 2023 batch of UG to present the welcome song. This talented group of students has prepared a wonderful performance to kick off our conference on a high note. Please join me in giving them a warm round of applause.
से वीणा वाणी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते, सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते। हम शिशु है अज्ञानी माता, जिन चरणों का प्यार दे, वीणा वाणी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे।
Thank you, dear girls, for your beautiful performance. Now is the time for the speech by HOD sir. It is my great honor to introduce our esteemed head of department, Professor Dr. S.K. Khan sir, known for his visionary leadership and dedication to excellence. He has been a guiding force in our department. We are privileged to have him with us today to deliver the inaugural speech. Please join me in welcoming Professor Dr. S.K. Khan sir to the stage. Sir, please.
Hello, I Dr. S.K. Khan, Professor and HOD, Department of Anatomy, Darbhanga Medical College, come chairperson of this organizing team. I would have to give an privilege to welcome you all. Especially, I welcome everyone by heart to make this occasion grand success. I especially welcome our eminent speakers, Dr. Sunitha VC, additional professor of the PGMER, Pondicherry. Second eminent speaker, Dr. Padmaji, sir, and also Dr. Sontakke from the Pondicherry, who is also the eminent writer of the different anatomical books. I also welcome the other speakers, and most also he is the editorial chief of the Soca. Soca, full term of Soca is Society of Clinical Anatomy of India. Their eminent person, he is eminent person, renowned person of our anatomical society, Dr. Ravi, Professor AIIMS Gorakhpur. They all are on the online and our dignities. Also welcoming Dr. Vinod sir, BJ Secretary, Bihar and Jharkhand chapter of Anatomical Society Secretary, and the HOD of NMCH, Dr. Rasmi Prasad. I also welcome Dr. Zeba, who is also a speaker of this occasion. This type of CME should be continued for the advancement of our medical knowledge and also knowledge of the anatomy. So I welcome you again, all of you, including PG, UG students, media persons, staffs of this society, staff of this college. I welcome Dr. Hari Damodar Singh, Professor and Head, Department of Anesthesia of this college, and he is also Professor in charge of the in this college of student section. I welcome you all. आप सबको यहाँ हार्दिक स्वागत है, अभिनंदन है, धन्यवाद.
Thank you, sir. Now I would like to invite Dr. Seema Tabassum ma'am to continue the session.
Thank you. Now I request the scientific session chairpersons, Professor Vinod Kumar sir, Professor Rashmi Prasad ma'am, Dr. Padamjeet Panchal sir to stay on the dais to chair the scientific session. दे दीजिए उनको भी दे दीजिए. I welcome Dr. Hari Damodar sir to come on the stage. Our student section in charge, kindly come on the stage for facilitation. Our organizing secretary, Dr. G.S. Jha sir, will facilitate Dr. Hari Damodar Singh. It's time to proceed towards the scientific session. We are honored to have a special presentation to introduce all our guest speakers. I am delighted to invite Dr. Himanshi Jha, a dedicated learner and final year PG student of our department. She will introduce one of the leading experts and our guest speaker, Dr. Sunitha VC ma'am. Himanshi, come in.
A very charismatic good morning, everyone. It's my great honor and privilege to introduce one of our esteemed guest speaker today, Dr. Sunitha VC ma'am, Additional Professor, Department of Radiology, JIPMER, Pondicherry, is an illustrious expert in her field, known for her groundbreaking work and significant contribution to radiology and medical imaging. Her insights has been invaluable in both clinical practice and academic research. Fetal imaging, breast imaging, and interventions are her areas of special interest. She has 40 journal publications and 1 book chapter. She is associate editor and reviewer of IJRI and Indographics. She was governing council member of BISI from 2021 to 2023. She is a member of specialty board for fetal radiology and of National Board of Examination. We are incredibly fortunate to have ma'am with us to share her expertise and perspective on intersection of anatomy and radiology, offering us deeper understanding of how radiological advancement continue to enhance our anatomical knowledge. I would like to call you ma'am with the say, गुलों में रंग भरे, बादे नौ बहार चले, गुलों में रंग भरे, बादे नौ बहार चले, चले भी आओ कि गुलशन का कारोबार चले. A very warm welcome, ma'am.
Thank you. Thank you.
Ma'am, please unmute yourself.
I'm unmuted. Am I audible?
Yes, ma'am.
Okay. So can I start now?
Yes, ma'am.
Okay. So thank you for the kind words of introduction. First of all, I would like to thank the organizing team for inviting me for this CME great educational opportunity of this anatomical imaging. And I may be the odd person out in this session. Most of you must be from the field of anatomy. Anyway, so I may not be going to the depths of anatomy here, but I will be talking more about my field, that is radiology, how imaging can help deciphering the vascular anatomy. And that will be what I'll be concentrating today. So I'm going to share my presentation now. Is my screen visible now?
Yes, ma'am.
Okay. So I will go straight ahead to the topic. So the topic is deciphering vascular anatomy by imaging. We will be discussing about how the various modalities of imaging can be utilized for imaging the blood vessels and what are their clinical applications. So first about the different techniques. There are many techniques, imaging techniques available, but we will be concentrating only on the most commonly used and the modalities which have most clinical applications. The basic one or the most commonly used one is the color Doppler imaging. In any emergency setting, if you see, this is one of the basic imaging which is available in almost every place. And the second one is CT angiogram. So CT also is nowadays widely available in most places. The next is a little advanced, that is MR angiogram, which is a little more time taking, needs a more like a better setup compared to a CT, and it's a little advanced modality compared to the other two. And finally, the interventional technique, that is digital subtraction angiogram. So let's see what are the applications of these. And so each of these modalities has its own merits, demerits, utilities, and limitations, etc. So first, let's look at the color Doppler imaging, how we can look at the vessels with color Doppler imaging. So all of you must be aware that Doppler is done with the same ultrasound machine what we used to do other like B mode scanning. And what is Doppler imaging? So Doppler, the principle what we use is we use the Doppler frequency shift, that is the Doppler principle produced by moving objects. Like for example, if you are standing in a bus stop and you are hearing an ambulance approaching you, as the ambulance approaches you, the horn, sound of the horn becomes more louder and clearer. It means the frequency of the waves are increasing as the like moving object approaches you. Whereas when it leaves you and it's far away from you, the sound becomes lower and the frequency of the sound waves becomes lesser. The same principle, the change in the Doppler frequency is what we use in Doppler imaging to measure the flow as well as the velocity of the blood. So in ultrasound machine, most of the peripheral vessels like either the carotid vessel or the upper limb or lower limb arteries, they are usually imaged using a higher frequency probe which has a linear configuration. Its surface will be flat. And for abdominal organs, abdominal blood vessels like aorta, IVC, portal vein, etc., we use a higher, lower frequency curvy linear probe. So the like why we are using a high frequency for peripheral and lower for deeper structures is when the frequency is higher, the depth of penetration of the sound waves will be lesser. So for peripheral vessels, we want a clearer, good resolution image, but the depth of penetration can be smaller. So the frequency range is 4 to 12. Whereas for abdominal structures, you can see the linear probe with a flat surface. It has a very smaller footprint, that the area field of view will be smaller. Whereas for abdominal aorta, etc., we use a lower frequency, that is 2 to 5 megahertz, because it has to penetrate the entire thickness of the abdomen and reach into the retroperitoneal region. So we need a higher field of view and hence lower frequency. So lower frequency sound waves have a better penetration. So that is the concept of linear probe and curvilinear probe. Now, the advantage of color Doppler is, one is its wide availability. Ultrasound machine will be available in almost every place nowadays, every healthcare institution. So it does not require intravenous contrast and no preparation of the patient before the study. A peripheral Doppler can be done as and when the patient comes. It doesn't require empty stomach, no fasting, nothing. And no radiation exposure. That is the biggest advantage. So we can repeat the procedure how many ever times we want without any adverse effects to the patient. So these are advantages of a color Doppler. But what are the disadvantages of a color Doppler? Can we use color Doppler to image the entire blood vessels of the body? Definitely no. So one is it's operator dependent. Unlike the CT images, where you do a CT and acquire the entire set of images, and even a radiologist or a clinician sitting at a faraway place, if they are provided with those images, the complete information will be available without any loss of information. Whereas in ultrasound, it's always operator dependent. The person who is performing should know where I have to scan and which vessel I am imaging, and they have to save those images. But it's not possible to save the image of the entire blood vessel from origin to termination, as well as there may be some obscuring factors, like if it's abdominal aorta and if the patient has just a lot of gas in the abdomen, that will limit its visibility, which is not at all a problem in a CT. And similarly, in obese patients and all, the visibility has a lot of challenges in ultrasounds. And another is the limited field of view. As I told, it's not possible to have the entire course of the vessel imaged in one image. So these are the advantages and disadvantages of a Doppler imaging. But definitely, it has a lot of applications. Now, coming to the aspects of color Doppler imaging, it has 3 components. First one is a grayscale. Just like we do in ultrasound, we get black and white images, and that is grayscale. So what do we use these grayscale images for? That gives you the anatomical details of the blood vessels, like the size of the blood vessels, whether there is any pathologies in the lumen, such as narrowing, or whether there is any thrombus, whether there is any atheromatous plaques, or there is any dissection in the vessel. All these anatomical or morphological information we get with a grayscale. In addition, you can also see the adjacent structures. Sometimes there may be a mass lesion which is either infiltrating or occluding the blood vessel. That can also be picked up with the help of a grayscale image. Next is color flow. So here, into the black lumen, when we switch on the color box, that will give color within that. That will give some color filling depending on the flow velocity as well as the direction. So color flow is used to assess the flow within the vessel, and depending on the velocity, whether it's a very high flow or very low sluggish flow, it will give the intensity of color. So some subjective idea about the velocity and direction of flow. Next is spectral tracing, which is more of a quantitative imaging. Here we get the direction of the flow pattern, that is through the entire cardiac cycle, how much it increases during systole, how much the flow decreases during diastole, and which direction it is flowing. All these details we get in a spectral tracing. So let's see each of these images. So first one, as I told, is a image. It's a image, also known as BB. So we are seeing the common carotid artery here, and adjacent one, superficial to it, is the jugular vein. So when we switch on the color box, you can see this rectangular box. That is the color box. So you are seeing red color within the carotid artery and blue color within the jugular vein. So there is no hard and fast rule like artery will be shown in red and vein will be shown in blue. It's not like that. When you keep the probe, if the blood is flowing towards you, for example, if it's a carotid artery, you're keeping the probe on the patient's neck, blood is coming from the heart towards the brain. So it is approaching the probe. So it is shown in red. That is the concept. When the flow is towards the probe, it will be shown as red. When the flow is away, like in the jugular vein, the flow is coming from the brain, going away from the probe towards the heart. So it is shown in blue. And next, the third mode is the spectral, where you get the tracing of the blood flow. That is, it is increasing and reaching a peak in the systole, then it is gradually reducing, and in the diastole, it is a lower flow. So in central vessels like carotid vessels, or in the visceral vessels like mesenteric vessels, renal vessels, etc., always the flow will be continuous forward flow. Whereas in the peripheral vessels like femoral artery, upper limb arteries, etc., where the inherent resistance of the vessels are higher, there will be a small reversal in the early diastole. So here it is a carotid vessel, so there is no reversal. But in the peripheral vessels with higher peripheral resistance, there will be a small dip in the reverse direction in the early diastole. That is known as triphasic waveform. So sometimes you must have heard of duplex scan. So what is meant by duplex? Duplex is nothing but the simultaneous display of either the color of grayscale along with spectral tracing. So you see both simultaneously. You see the color flow and you see the spectral tracing in the same screen simultaneously. So if you want to, this line you are seeing, this is the small sample volume from where you are measuring the velocity of the blood, or we are taking the spectral tracing. So if you want to take it from some other place, that can be done in a live mode. You can change the position of the sample volume, keep tracing from another location. So there is another modification of the color Doppler that is known as power Doppler. So in color mode, we told that it is depending on the direction of flow, it is displayed as blue and red. So you can see the scale here, red on top, blue on the bottom. So depending on which direction it is flowing, the vessels will be displayed. Arteries will be red if they are coming towards you. That depends on your probe location. But power Doppler is something which is it is not dependent on the flow direction. It is only dependent on the flow velocity. Okay, it's how much powerful the flow is. So this is useful when we are not concerned about direction, but we are concerned whether an organ is having some vascularity or not. So even very minimal flow can be detected with the help of the power Doppler. So this is just a comparison. As I told earlier, peripheral arteries have a triphasic waveform. upstroke in the systole, early diastole has a small reversal, and then forward in the end of diastole. And in the central arteries, it has a continuous forward flow. So first one is femoral, second is carotid. So this is how you will keep the probe in case of a carotid Doppler. In the neck, just lateral to the thyroid glands. So grayscale will show you the anatomy. And here in this picture, you can see this pictorial representation shows there is a plaque formation in the internal carotid. This is common. Then just after the, use the pointer. So just, yeah. So here, using this, here there is a plaque formation and the luminal narrowing. So look at these images. The image on top in grayscale shows a plaque which is narrowing the lumen, and the color Doppler shows reduced flow in the region of the plaque. We are not seeing any color fill in the region of the plaque. And when you check the velocity, so usually when there is narrowing, the velocity will increase at the narrowed point to certain extent where it can still pass through. But when it reaches a critical stage, this flow may be completely occluded. So here it is like a partial narrowing. So flow is still there, so but the jet has a higher velocity here, higher than normal. So let's see one video of a Doppler. So this is a common carotid artery in grayscale. So this is the bifurcation of the common carotid into external and internal carotid artery. Now we are changing the plane from axial section to longitudinal section, which is ideal for spectral tracing and color flow. Now it is changed to longitudinal. This is common carotid artery. Now we will switch on the color box. So it is taking up the red color. The flow is towards the probe. And now we will switch on the spectral tracing after this. So we are seeing that there is no plaque. The lumen is very clear. We have taken a sample volume, and now we get the spectral tracing of the common carotid. It's a normal waveform. So next, we will see this is after the bifurcation of the common carotid into internal and external. So we are focusing on the internal carotid now. So here also we will switch on the color box now. And we will take the sample volume. So the spectral tracing gives a low resistance waveforms. Now we will move on to external carotid. Where you do a CT and this is external carotid. So we have put on the color. Now we will take a spectral tracing here. Sample volume is kept in the center of the vessel. Now look at the waveforms of external carotid and internal carotid. So external carotid mainly supplies the head and neck blood vessels. So it has a higher peripheral resistance, whereas ICS supplies mainly the cerebral structure. So it is having a lower resistance continuous flow. Now coming to a few words on the common color Doppler of the lower limb arteries. So you are all familiar with this anatomy. So the structures what we usually see, the vessels which we usually image are common femoral, superficial femoral, popliteal, then the terminal branches like posterior tibial, anterior tibial, peroneal and dorsalis pedis artery. So femoral and popliteal arteries are always visible with the accompanying vein or the corresponding vein, femoral vein and popliteal vein, whereas anterior tibial artery, posterior tibial artery, peroneal artery, these leg arteries will be combined with two veins, two accompanying veins, that is venae comitants. So this is how usually we will keep you can keep the leg straight also and keep the probe starting from the inguinal ligament region and come gradually scanning to the entire thigh. Then you can either keep the probe by asking the patient to flex the knee and keep the probe from behind, or you can ask the patient to lie prone and then look for the popliteal artery. So at the thigh, upper thigh, the common femoral will appear like this and it bifurcates into superficial femoral and profunda. In cross section, they will look like this, the artery being lateral to the vein. So this is superficial femoral, a little lower in the thigh, in longitudinal section and cross section. So this is in the leg. So as I told earlier, it's impossible to get the entire stretch of the vessel with ultrasound. But there are some technologies like stitching of the images, panoramic views available, where you can just interconnect multiple images and make it into appear as a single image. But while taking the image, you have to go step by step at each level. So this is entire leg vessel from the then to the popliteal and tibial and peroneal and anterior tibial and posterior tibial and peroneal arteries. So here the next image shows the accompanying venae comitants along with posterior tibial and peroneal. So this is an image, cross-sectional image in the upper abdomen showing the abdominal aorta as a round dark structure, and adjacent to it is the IVC. And this is a longitudinal section, and this is the spectral tracing. And this last image shows the color flow imaging of the aorta, with the superior mesenteric artery can be seen taking off from the anterior aspect. So which are the pathologies or what are the indications for Doppler imaging in usual clinical practice? So it can be, most common indication in emergency is an acute deep venous thrombosis, that is imaging of the veins, where patient presents with acute pain and swelling of the legs, or some polytrauma patient, or some bedridden patients. So that is the most common indication. Other than that, you get request for carotid Doppler in case of stroke, transient ischemic attacks, or for peripheral Doppler for in case of TAO, peripheral vascular diseases. Then arterial and venous thrombosis. Then focal Dopplers, like regional Doppler, you can be asked to do Doppler for, especially in peripheral vessels, means post-traumatic pseudoaneurysms. Look for pseudoaneurysms after trauma. Then some regional AV malformations or arteriovenous fistula. So these are some common indications. Let's see one or two cases where Doppler has picked up some pathology. So in the first one, you can see a plaque in the carotid at the bifurcation, exactly at the carotid bulb. And this is the cross section where we can measure the percentage of the stenosis. That will tell you this is a 56.7% stenosis. In cross section, take the outer area and the inner area, excluding the plaque. That will give you the compromise, how much percentage is stenosis. So more than 60 to 70% and all will be a significant or critical stenosis. And this is how this color Doppler that is showing some turbulence within. It's not a clean red flow. It is having a mixture of red and blue that indicates that through that narrowed segment, blood is flowing at a high velocity. So that arrow just shows the plaque. So this is a peripheral. The first picture is a normal femoral artery showing a triphasic flow, and the second one is showing a narrowing in the superficial femoral artery with a turbulent flow and an extremely high velocity. See, the velocity is 400, which is significantly higher for a femoral artery. This is a peripheral artery aneurysm. So it's a saccular aneurysm. So the sign, the appearance of the blood flow within an aneurysm is known as yin-yang sign. Here what happens is through the narrow neck, blood enters into the pseudoaneurysm. Then again, it goes back into the lumen. So that is why this appearance, blue and opposite direction, flow in the opposite direction. It is known as the yin-yang sign, which is a Chinese concept of darkness and light, or day and night, etc. Now coming to the other modalities, that is CT and MR angiography. So nowadays, the CT and MRI are the backbone of vascular imaging. So whatever disadvantages which we mentioned about the color Doppler, we can circumvent with the help of CT and MR imaging. So this, the invasiveness in CT and MR, in CT especially, it is just an injection of intravenous contrast. Otherwise, it is a non-invasive procedure. You can consider it as a more or less non-invasive procedure. Whereas MRI, it is possible to have without contrast also we can have, especially the cerebral angiogram, we can do without even contrast. So CT and MR angiography combines the non-invasiveness, and its resolution is extremely good, both spatial as well as temporal resolution. And we take the images in CT particularly, we acquire the images in the axial plane, and without even changing the patient's position or the equipment's position, we can get reconstructed images in all the planes, like sagittal, coronal, and whichever plane we want, we can get multiplanar reconstructed images. And there are other post-processing methods also which improve the visibility of blood vessels. So advantages, CT is faster, high resolution, multiplanar reconstructions, minimally invasive, less affected by the operator's experience. As I told earlier, you acquire a set of images and a radiologist sitting at a faraway place can see the entire set of images without even having seen the patient. And disadvantages, CT angiography almost always requires the use of intravenous iodinated contrast injection. So in those patients which is contrast is contraindicated, we cannot do a CT angio. For example, patient with a known anaphylaxis and patients with CKD. And it has
Slide is not visible, madam.
Ma'am, your slide is not visible. Please.
Okay.
Please, ma'am,
Okay.
please share the screen.
I will stop and share again.
Yes, ma'am, please.
Okay. From which slide it was not visible?
Just share from current slide only.
Okay, okay. Is it visible now?
Yes, ma'am. Now it is.
Okay. So now we move on to CT angiogram. So CT angiogram, there are different regions where we do CT angiogram. The most common one is a cerebral and neck vessel angio. Then another most commonly done angiogram is CT for the coronary blood vessels. This has been very phenomenal change. It has brought a very phenomenal change because previously in most of the situation, the only option to image the coronary vessels was an invasive digital subtraction angiogram, but with its own risk. But if you are not planning for an interventional procedure to correct in that patient, only doing a diagnostic angio is a little risky for the patient. So that can be, in many of the situations, CT coronary angiogram can replace a diagnostic angiogram, conventional angiogram. Next, we can do CT angio for thoracic and abdominal aorta and its branches and for the peripheral arteries. So since cerebral CT angio is the most commonly done, we will just look at some details of CT angio of the brain. So most common indication, stroke, then subarachnoid hemorrhage to look for any aneurysm, because in 70% of the cases when there is subarachnoid hemorrhage, there will be a ruptured aneurysm of any of the branches of the circle of Willis. Then other conditions are cerebral hemorrhage, where parenchymal hemorrhage, where you look for some vascular malformations underlying in the brain, or even a post-traumatic brain injury. So in the brain CT angio, we start from the level of aorta, include bilateral internal carotid, external carotid, and vertebral arteries, plus the circle of Willis branches. So this is how we plan a CT angio. The patient will be lying supine in the CT table with arms by their side. They already an IV line must have been secured. So we take the scout image. Scout image is the initial image where we plan the sections. So we take from the mid-thorax to the vertex. And the scan direction is from caudocranial. So we start from the arch of aorta and go to the vertex. And contrast dosage is approximately 50 to 75 ml. That dosage is 1 to 1.5 ml per kg body weight. And at a rate of 4.5 to 5 ml per second. So preferable to use a pressure injector for a controlled injection. So after acquiring the axial images, we can do many reconstructions, multiplanar in axial, coronal, or sagittal, which is a dictum. Like every case, there will be a reconstructed images also available. In addition, we can do maximum intensity projection reconstruction. That is, here the pixels. Pixels means each point in an image in the CT is known as a pixel. It's a two-dimensional image. So if you take an axial section, any single point is known as a pixel. So when we inject contrast, the density of the brightness of the blood vessels will become much higher compared to the surrounding soft tissues. So when we select maximum intensity projection, we give a threshold value. Like for example, 100. The density of pixel as 100. So every structure above the 100 Hounsfield unit, the unit of CT density is Hounsfield unit. Above 100 will be selected. So all the blood vessels which have iodine with it will only be selected. Rest of the soft tissues will be discarded. So that will give you a maximum intensity projection of the blood vessels. But here the disadvantage is The bones also have high density. Their Hounsfield value is also above 100. So they will also be opacified. But nowadays we have technique for bone removal, which the artificial intelligence has developed so much that we can, with the click of just one button, all the bones will be removed and we will get only the images of the blood vessels. Other applications are, other post-processing techniques are curved planar reformats, shaded surface display, or the 3D volume rendered image. We will just look at some images, we will get a clearer idea. So this is a MIP image, which I was telling, that we are selecting only pixels with high density above 100. So it gives the abdominal aorta, its renal branches. This is a curved planar reformat. This is a carotid right coronary artery. So not carotid, coronary artery. So say, look at the vessel, it is going in a very curved course. So what we do is, in the axial sections, we select the image in each section, and then it will be stitched together to give this curved reformat. And this is a volume rendered, which gives you a realistic picture of the blood vessels. This is again the coronary artery, left coronary artery with its branches, circumflex and the anterior descending branch. Now coming to MR angiogram, the images may look more or less similar, but the advantages here in MR angiogram is, especially the cerebral, so there is no ionizing radiation. So this is safer in pregnant women, and for repeated examinations also it is safer. It can be done without contrast, particularly the brain angio can be done without contrast because that has mainly stationary tissues and it doesn't have any moving structures. Whereas in thoracic, abdominal aorta, etc., lot of moving structures are like heart, lung, bowel, etc. In those areas, non-contrast angiogram will not give a good result, so we have to inject some contrast. And compared to the iodinated contrast, gadolinium is less nephrotoxic in persons with good renal function. Then another thing is, the most commonly used technique for cerebral angio is known as time of flight. I am not going to the details of the physics of MRI, so we will just look at the vascular anatomy in angio and how in imaging this anatomy is looking. So now we all know brain is supplied by two sets of vessels, anterior circulation predominantly by the internal carotid arteries and its branches, which supplies almost 2/3, posterior circulation mainly by the vertebral artery, which is a branch of the subclavian artery. And there is a good amount of anastomosis, and it when one circulation is compromised, the other one will compensate for that. So here is an MIP image or a volume rendered image of a CT angiogram, which clearly shows the blood vessels in the neck as well as the brain. So here we will just try to look at the blood vessels here. So this is the arch of aorta, first branch, brachiocephalic trunk, which divides into subclavian and right common carotid. Again, that divides into external and internal. Next branch, that is left common carotid, and the third branch is the subclavian. So the vertebral artery, you can see it arising from the subclavian artery. And in the brain, you can see the internal carotid going through the cervical and petrous segments, and then terminating by dividing into middle cerebral artery and anterior cerebral artery. Similarly, both the vertebral arteries go up and they join as the basilar artery and terminate by bifurcating into posterior cerebral artery. This is just an overview. We can see some of the actual images, and we will try to interpret these. So this is actual CT angiogram. So we have kept our starting point at the level of arch of aorta. In this image, it has just started below the level of arch, where you can see the bifurcation of the pulmonary artery. The starting point here is the bifurcation of the pulmonary artery. Now we are going up. So here you are seeing two vessels, one here and another, so two cross sections. So because of the injection of the contrast, these blood vessels are appearing very bright. So the anterior round, what you are seeing is the ascending aorta, and the posterior one is the descending aorta. So as you go up, your arch has come. So arch of aorta traveling from anterior to posterior, from right to left. Now the branching starts. So we can see three structures here, rounded structures. The first one, the brachiocephalic, then the left common carotid, left subclavian. So now we are going ahead, going upwards. So both subclavians have gone into the upper limb. Now concentrate on the left common carotid first. So this is the left common carotid artery. Now I am going up, tracing it upwards, and you can see the circle going. And now it is dividing into two vessels. You can see one is anterior and medial one is smaller, and the posterior and lateral one is larger. So this is the smaller one is the external carotid, and the larger one is the internal carotid. Now I am going further up. The external carotid is giving off its branches in the neck. We know that it has some 7 branches, and it's giving off its branches in the neck. You also notice that internal carotid has no branches in the cervical part. Now now concentrate on the internal carotid. It is moving. So I will just point it. It is moving medially and anteriorly. Now it has entered into a bony canal. So that is the petrous part. So it has entered into the petrous part, and then you concentrate again on it. It is in the carotid canal now, and now it is in the cavernous sinus. So it is going anteriorly, and at the clinoid, it is taking a turn and finally bifurcating into middle cerebral artery and anterior cerebral arteries. So can you appreciate the middle cerebral here? I will show once again. The middle cerebral arteries and two anterior cerebral arteries going anteriorly. So this is how we acquire the images and how they appear. So one thing I wanted to show here is there is a small variation in the left common carotid branching. So if you look at the left side, you can see 2 vessels on the right side, whereas a single vessel on the left. So that means on the right side, the common carotid, there is no common carotid, but both external and internal arise as separately from the arch of aorta, like brachiocephalic trunk. So there is a very early branching of the common carotid into internal and external. So that is an anatomic variation. So these are the coronal and sagittal reformats. This first one is a coronal reformat. So here you can see the bifurcation of the right common carotid into internal and external a little early. So it's like almost straight away they are taking as separate branches from the brachiocephaly. And here we have a sagittal reformat. So here the left common carotid can be very clearly seen branching. The common carotid and branching into external, which gives off some branches, and the internal, which is going posteriorly and then upwards into the brain. So this is a volume rendered or surface shaded volume rendered technique, which after removal of the bones, which I was talking about earlier. So you can also see another vessel here in the sagittal location. So that is the contamination, venous contamination, that even veins have started opacifying, and the superior sagittal sinus and other transverse sinus are seen in this picture. And now we will compare an MR angiogram with a CT angiogram. So here, same cross sections, axial sections, you can see both internal carotid arteries, their curvatures, and terminating into MCA and ACA. We can also see the both vertebral arteries here, both vertebral arteries joining to form the basilar, and then that is terminating by dividing into posterior cerebral arteries. And the second image is a coronal reconstruction of MR angiogram. So we can see the tortuous course of the internal carotid and its terminal bifurcation. Similarly, here the both vertebral arteries joining into basilar and finally terminating into the posterior cerebral. So these are the MIP images, single images. Previously we saw the serial sections. Now it is a single image of circle of Willis in the axial and the coronal plane in the MR angiogram. So this is, I'm not going to the details of these segments. It's both, there are different classifications. ICA has various segments. These are important in, whereas interventional radiology point of view and clinical, like when you do some specific procedures, so it is very important to segment the internal carotid into particular segments for the purpose of interventional procedures. So the names are cervical, petrous segment, lacerum segment, cavernous segment, clinoid segment, ophthalmic, and the communicating. 7 segments. So same in a lateral digital subtraction angiography image. Now, in the brain circle of Willis also there are different segments. So I think it's better that I don't go to these details since I'm not going to the details of the anatomy per se, but how these vessels look in an imaging is what I would like to concentrate. So ACA has different segments and all these can be appreciated in the angiograms. And these are the segments of the middle cerebral artery, the horizontal M1 segment, Sylvian segment that is M2 and its cortical branches that is M3, and the segments of the PCA before origin of the posterior communicating, and P2 is a part distal to P2. So now we will just look at one coronary artery CT also, and with that, after that we will see some cases. So here we are having a very limited field of view in coronary because we need a very good image resolution for getting a diagnosis in coronary angio. So look at the image field of view. It is concentrating only in the heart region. So you can see this is the ascending aorta. So this is the left coronary origin, which is dividing into the circumflex and descending branches. And you can see the right coronary origin anteriorly and its branching. So after we take the source images, we do curved planar reconstructions of individual coronary arteries. So first is the right coronary, second is anterior descending branch of the left coronary, and the circumflex branch of the left coronary in curved planar reformat. And then we also do volume rendered reconstructed images. So this gives a very good image clarity and very good resolution, and without invasive procedures we can come to a certain extent about the anatomical and morphological variations. Now quickly we will see some of the cases where CT angio or MR angio has provided us with the diagnosis. So case 1, we are going to see the angiogram images, CT angiogram of the thoracic aorta. So you can see in the arch of aorta, there is a membrane-like structure within, and that is continuing down into the thoracic aorta up to the renal artery. It is reached even below the renal artery origin. So up to here. So what is that structure? You are seeing 2 lumens separated by a dark membrane-like structure, and that has started from arch of it has started from the arch. It is extending entire like ascending aorta, started from the ascending aorta, entire arch is involved and descending aorta is involved, and reached up to the infrarenal segment. And second image is a coronal reconstruction of the same case. So here you get a better picture. You can see the extent of the membrane. So this was a case of aortic dissection. So you know what is aortic dissection? It's a tear in the intima, and it's classified as Stanford A because of the involvement of the ascending arch and the descending Stanford A type. And this is a volume rendered image which is showing a clear extent of the dissection in the lumen. So next case is, it's a companion case. So you know that it is also a case of dissection. So here the ascending aorta and arch are spared, but it is involving only the descending aorta. But in the previous case, we saw both the lumens were opacified with contrast, but here the second lumen has some hematoma in it. Okay, partially it is having some hematoma, but inferiorly it is having opacification. So it's a thrombus within the dissection. So this is this is a Stanford B type of dissection. So case number 3. So here again it's aorta. So what we are seeing is extreme dilatation of the arch and descending thoracic aorta with hematoma or thrombus in the wall. So this is a case of aneurysmal dilatation. So it is stopping short of just above the renal vessels. So it's a suprarenal aortic aneurysm. So let's see the coronal reconstruction. So you will be able to appreciate the entire extent of the aneurysmal dilatation. So how big it is. So we know when a patient presents with acute severe pain in the chest or upper abdomen, like if it is not suggestive of MI with EEG or ECG or other investigations, you should always consider a possibility of either a dissection or an impending rupture in an aneurysmal aorta. So this is another case of infrarenal aneurysmal dilatation, huge dilatation. So any diameter above 6 centimeter has a 10% chance of rupture within the next 6 months. So here the second picture is showing the reconstructed image, volume rendered image, where a fusiform dilatation of the infrarenal segment of the aorta is seen. So this is a case of a cerebral angio. We'll quickly finish this. So here this patient presented with some subarachnoid hemorrhage. So carefully look at the anterior communicating artery. You can see one small round bulge here. So this is an ACOM aneurysm, anterior communicating artery aneurysm in axial section. And here you have the sagittal section, again showing the ACOM aneurysm here. You can look at here. This is the ACOM aneurysm in the sagittal plane. So same case when digital subtraction angiography was done. So here you can clearly see the aneurysm. So this will be followed by a coiling procedure for occluding that aneurysm. So this is a reconstructed image which is showing the aneurysm in this. So last, okay, we will skip this and we will see this case. So here, this is MRI of the brain, which is showing in the anterior part of the left frontal lobe. We are seeing some altered signal changes in all the T1, T2 and FLAIR images. There are altered signal in the anterior aspect of the left frontal lobe. Now we will go to the angio. This is a susceptibility weighted image, which is sensitive for detecting hemorrhage within the brain parenchyma. So it is showing very dark areas, which is suggestive of chronic bleed. And this is a MIP image, which is showing very prominent blood vessels in the brain, supplying that region rising from the middle cerebral artery. And you can also see some prominent veins draining into the superior sagittal sinus. So this is an AV malformation. And last case. So here a plain CT is showing some subarachnoid hemorrhage in the posterior occipital region. So we have done a CT angio for this case, and you can see very tortuous blood vessels in that region with a nidus. So this is also a case of AV malformation, left occipital AV malformation. So with that, I have come to the end of my presentation. Once again, I thank all the organizing team, and for patient listening, I thank all the audience in this session. Thank you once again.
Content shared by Dr. Sunitha VC ma'am.
Thank you, ma'am.
For the wonderful session. Now I request our chairperson to ask questions. If anybody have question from the delegates, please click on the raise hand icon button. Please ask questions if you have. Ma'am.
Anyone, if you, anyone want to ask any question, they can ask.
Madam, I have a question. Can I ask?
Yes.
Madam, what would be the indications for coronary CT angio than normal regular angio?
Okay, so coronary CT angio, if the patient does not has, especially this unstable angina patients, they don't want to go for an invasive procedure like a conventional digital subtraction angio. They can go for a coronary CT as a first-line investigation, whether it's actually caused by a compromised coronary circulation or not. Unstable angina patients are one of the major problems. Then definitely almost we can do it. Calcium scoring is nowadays done as part of regular heart checkup, where we will score the calcium level in a patient's coronary arteries, and if needed only we can proceed with a contrast angiography.
Still, should we advocate patients move to for a normal convention or for CT method? Ultimately, if there has to be some intervention, We have to go for a conventional.
Yes, yes, that's what. This will be like initial screening modality. And if they need an interventional procedures like stent placement and all, definitely they have to go for it. So acute situations, it's not that much indicated, like acute MI, where an emergency life-saving stent placement is indicated. It is not advisable. But not so acute conditions where you are suspecting, like imaging can give an insight without going for an interventional procedure.
Okay, thank you so much.
I want to ask, with the increasing Tesla in the radiological imaging,
Yes.
how does it affect the quality of the image and the anatomical aspect of the suppose brain?
Okay, so more and the higher Tesla means 1.5 is the usual one, but 3 Tesla and even 7 Tesla are available now. But these applications are much more higher for structures like musculoskeletal, where we have a better visualization of the tendons, ligaments, etc., rather than the cerebral vessels. Because cerebral vessels with 1.5 also we get reasonably good quality, but it definitely 3 Tesla has its advantage with like slightly lesser scanning time, etc. So, but it's not mandatory that you should always do a 3 Tesla only for cerebral angio. But it is more preferable. The higher Teslas are more preferable. Others like MSK particularly, MSK, and there are other applications also. But it is okay if you do a 1.5 Tesla also for cerebral angios. Any inputs on radiation hazards? Yes, radiation hazards are there in any CT scan. It is around, if you compare a CT scan with the chest X-ray, it is around 40 times higher. So always use it judiciously, and you should not repeat it right and left CT scan for patients. So always have the use, like it should be like cost effectiveness plus risk benefit ratio. It has a radiation risk, but so we hope that we are doing a CT that will be a single episode and the patient may not be requiring repeated CT. If you are requiring repeated CT, go for an MRI and go for a Doppler.
Very nice presentation, ma'am, Dr. Sunitha. Would you tell me which should we prefer more, the CT angio or the MRI angiogram? Which for any, say, cerebral,
No, CT angiogram, if the patient doesn't have any contraindication, a CT angiogram is good. It has a very good resolution. But there are specific indications for MR angiogram. One thing is it can be combined with a MRI of the brain parenchyma. So that information is not comparable to a CT brain. The information of MRI brain, information we get from MRI brain is not comparable to the information we get from the CT brain. So if you are combining it with an MRI brain, then it definitely has a superior value for parenchymal imaging. Plus, it gives an information on the blood vessels. For the purpose of evaluation of the cerebral blood vessels, CT has a role. CT angio has a good resolution. And another thing is it can be acquired very fast in trauma settings, in stroke settings. Instead of waiting for an MRI, which takes 20 to 30 minutes minimum, you can finish this procedure within less than 5 minutes. So that advantage is definitely there and gives a reasonably good resolution also. Information about the blood vessels much better, but other parenchymal information is significantly better with an MRI.
Dr. Shivangu Thakur, she's waiting, and Dilshad Anwar, they are waiting for their questions to be asked, to ask from you.
Okay.
Ma'am.
Can you please ask the question?
Ma'am, with this so much advancement in the imaging technique, can you have MR with the pacemaker on?
MRI pacemakers are now conditional. Previously, it was a 100% contraindication, but nowadays, since with the advancement of technology, there are conditional pacemakers where a specific person who is who is aware of the settings of the pacemaker, or even a cardiologist, they have to limit the duration of the exposure within the magnetic field, etc. It is possible, but in nowadays in our setup, in my institute at least, we are not doing any pacemaker, any MRI for patients with pacemaker, because we don't know, we cannot ensure the safety unless the cardiologist is accompanying and they are ensuring that this is an MRI conditional which can be utilized. And they say the time duration also has to be restricted. So each pacemaker will have a leaflet attached with it, whether it is a conditional MRI conditional or it's a contraindicated. So it's not a 100% rule for all.
Okay, thank you.
Dr. Shivangi, you can unmute yourself and ask question. Thank you, ma'am.
Okay.
Thank you, Dr. Sunitha. And I would request the participants who have participated for the models to present their models on the stage. Thank you.
बोलो इसको बड़ा कैसे करेंगे? देखो तो ये बड़ा कैसे करेंगे इसको? ये वाला ये
Now, one of our first year PG, Dr. Archana Prakash, a very sincere resident of our department, will introduce our next guest speaker, Dr. Yogesh Sontakke, sir. Welcome, Archana.
Thank you very much, ma'am. Good morning, everyone. I, Dr. Archana Prakash, with an immense pleasure, would like to introduce a truly remarkable individual who has significantly contributed to our field of anatomy. Dr. Yogesh Sontakke, sir, Additional Professor, Department of Anatomy, Academic Center, JIPMER, Pondicherry. Not only the vast experience of teaching UG and PG, he is also editor and editorial board member and has 61 publications in various national and international journals. He has an illustrious career, decorated with numerous accolades, including member of Terminologica Anatomica, International Federation of Association of Anatomists, Excellence Award in Medical Education 2022 by IMA Tamil Nadu, Editor-in-Chief for National Journal of Society of Medical Anatomists. In addition to these, he also has served as author and editor for various books of anatomy. With an expertise in Adobe Illustrator software for drawing medical illustration and Premiere Pro software for editing educational videos, he also took initiative in development of e-platform for faculties and students containing videos, MCQs, PPTs. We are truly incredibly fortunate to have him with us today. So without further ado, please join me in welcoming Dr. Yogesh Sontakke sir to share his insights. Thank you.
Thank you so much for the nice introduction. Am I audible, sir? Hope so. I am audible now.
Yes, yes, sir, you are audible, sir.
Yes, sir. Thank you. So I will share the screen. So PowerPoint is visible now, sir?
Yes, sir.
Okay. So I will start the presentation now. So today's topic, I would like to share some thoughts on the journey of radiological scanning images to digital 3D anatomy model creation. Before I start my talk, I want to say special thanks to Dr. K.N. Mishra, Principal, Darbhanga Medical College and Hospital, Professor Dr. S.K. Khan, sir, who is organizing chairman, Dr. G.S. Jha, sir, organizing secretary, very enthusiastic person. Thank you, sir. Thanks for the invitation. Dr. Archana Gautam, co-organizing secretary, Dr. Subodh Kumar, Dr. Radhika Raman, Dr. Lalan Kumar Singh, Dr. MC Verma, Dr. Seema Tabassum, Dr. K.K. Mishra, and all the members of Department of Anatomy, Darbhanga Medical College for organizing this conference and their continuous support. I would like to also say special thanks to Dr. Vinod Kumar, sir, who is ex-professor of anatomy and principal, Narayan Medical College and Hospital, Dr. Ranjit Gua, sir, principal and professor of anatomy, IGMS Patna, Professor Dr. Rashmi Prasad, ma'am, HOD Department of Anatomy, NMCH, Dr. Padamjit Panchal, sir, additional professor, Department of Anatomy, AIIMS Patna. I am also especially thankful to Professor Shivkumar, sir, who is the guiding light for me throughout my career, and our beloved President of Society of Clinical Anatomists. Thank you, sir. Professor General Secretary-in-Chief NJCA, and all the office bearer of Society of Clinical Anatomists of India for organizing this CME and giving me the opportunity to interact with all of you. I am also especially thankful on behalf of Soca to Professor Sunitha that she has accepted our invitation and given a very nice talk. Thank you, ma'am. So this journey of radiological scanning images to digital 3D model creation, what exactly this topic and why we have selected this topic? When I see the postgraduates, they are coming and joining the anatomy, the concept of them is only to go in the medical college and to teach the anatomy. So that is one job opportunity. Other than that one, so what are the specialty, what are the other fields where anatomists can go and explore their careers? There are a lot of opportunities. One segment is IVF and embryology. And one is this segment that is the 3D model creation. Have you ever seen the anatomist table, the 3D anatomy table or the dissection table, digital dissection tables? So how they have created? Have you seen the virtual reality model? How they have created that virtual reality model? So there are a lot of opportunities. If someone good anatomist who is very much interested in the field, they can go and explore this career. So I want to make you aware about that field, how the career can be developed. Only don't keep you limited to the anatomy teaching. Explore the limits of the anatomy beyond certain levels. So these are that levels. Someone may not be interested in becoming a model creator or digital 3D model creator. But as a subject expert, we should have the knowledge, because as a teacher, you will have to tell to your students, only teaching anatomy is not the end of this field. If you see the medicine, they have a lot of DM branches. So here, no need of doing something super specialization after anatomy. Genetics, we can go and explore. Embryology, we can explore. And this digital anatomy, we can explore. And now this is flourishing field. So this radiological, we will see the journey now. Suppose one patient came, we have done the CT scan, and now we want to create the anatomy table or anatomy model. We can go for the 3D printing or whatsoever. So how this can be taken to that level? So I am not going to make you expert, but the knowledge is important. By this way, you should have certain knowledge, certain information to start your career with this. So radiological scanning, there are different types of the modality: CT scan, MRI, PET scan, and ultrasound. So these are the modalities which we can use to create the 3D models. Earlier days, our research was restricted towards the histology. In the histology, what we used to do? Sectioning, serial sectioning, one by one thin slices of the tissue we are making, and we are analyzing thin slices. So the living individual, we can't go every time for the histology. So in the living individual also, this type of sectioning using the MRI, PET scan, CT scan, and ultrasound, this is possible. So these sections can be analyzed further. So without destruction of the tissue, without disturbing the living cells, we can go for slicing using this type of the technique. So this radiological scanning images involves the acquisition of image process which acquires the images. So high resolution images are obtained using the sophisticated equipment and the techniques. Then after that one, these images need to be processed for creation of the 3D model, for better analysis, and for further our utilization. So this involves segmentation. We have to identify, see, a lot of things are there in the body. So we want to see only the vertebrae. We should have to select the area of interest, specific area of the interest, and that segmentation and other things. I will go step by step in further things. After that, we will create the 3D reconstructed model, and we will utilize this model for further analysis of the things. So these radiological scanning images are useful for early detection and diagnosis of the disease. Then these are non-invasive imaging modalities. So no need to cut the tissue, no need to collect the tissue. The tissue which can be there in the body of the patient. Heart, okay, 3D model we can create. No need to take out the heart even from the cadaver. Suppose you have aborted fetus and you want to do the study, research, analysis of the aborted fetus. No need to destroy the tissue. Without destruction, you can create the 3D model. What same thing is there in the body that can be created outside. It is helpful for guidance for the treatment and planning. Then monitoring of the disease progress. Suppose CT scan of the 1 month prior, and after the treatment, we are getting another one after 1 month of the treatment. So we can compare both the things and we can go for the monitoring of the disease progression. Then detection of the congenital anomalies. Like that one I have said, that embryological models also, aborted fetuses also, we can go for this scanning and we can detect easily the congenital anomalies. These congenital anomalies also can be detected using the ultrasound before the delivery. These are also useful for research and innovation. Many times when I meet the faculty, the concern is what topic to be given to the student. So these are the topics that can be given to the postgraduates, where they can explore more and more radiological anatomy. So before going for the image acquisition, we need some patient preparation. We have to tell some information that there may be, the patient has to avoid some food intake one day prior or the overnight. So like that one, we have to give some instruction to the patient. Then positioning and alignment. So if you want to create a good model, 3D model of the patient, then the proper alignment of the patient is important, because you want to create the model in the anatomical positions. So that positioning of the patient is important. What exactly you want to study based on that one. Then we have to consider the radiation exposure. Earlier, Dr. Sunitha ma'am was also saying, see, CT scan, one CT scan is equivalent to around 40 X-rays. So that radiological exposure, that hazard also, we have to keep in mind that only for the experimental purpose, we cannot ask the patient just undergo the CT scan. So ethical issues are there. Cadaveric CT scan, we can do it for the anatomical study. Aborted fetuses, we can use the CT scan for detection of the congenital anomalies in the aborted fetuses. Then suppose, for example, vasculatures you are studying or particular cavities you are studying. So you can use the contrast agent based on the requirement, what exactly you want output based on that one. So this preparation depends on your final output actually. So that you have to think. Storage and management of these images. So CT scan images, MRI images, there are different type PET scan images. So all these images nowadays, they are stored in the format called as DICOM. Earlier, we are very well versed with JPEG. Have you heard about JPEG, TIFF, PNG images? When we are submitting some data or some image to the journal, they will ask specification. Image should be in JPEG format. Like that one, these are the DICOM format images. So whatever may be the source, either X-ray, either maybe the ultrasound images or maybe CT scan, that images are stored in the format of DICOM file format. So this file format, along with the image, it stores the patient data also, like name of the patient, height of the patient, at what section we have taken. So a lot of things will be stored in this one. After that one, we have to use some storage things. That is the PACS, that is the Picture Archiving and Communication System, or RIS, Radiology Information System. So what exactly these things are there? So for example, earlier days, we used to take the printout of the radiograph, which will never be of a good quality like a digital images. It needs a lot of expenditure to develop that CT scan or the radiological images like a negative films. But nowadays the era is there where we are utilizing only the digital images. So suppose CT scan machine in the one center it has taken, and the doctor has to see from the other end. So he can see through the PACS, he can just log in and he can analyze the images using this picture archiving and communication system. So this DICOM images can be transferred from one system to the another using the PACS. Further, you are going to construct the 3D model using the radiological images. So image quality is important. It refers to the clarity. So here you can see the two images. The top image is not very much clear, but the bottom image is more clear. So how much clarity is there in your radiological image? Your final output of the model depends on the clarity. Here you can say output, or you can say for confirmed diagnosis. So whatever you say, that final outputs depends on the image quality. So what are the factors which affects the image quality? At least whatever errors are there, that we can remove. For example, equipment specifications. So equipment specifications are the main thing. So like in earlier session, they have discussed Tesla 1, Tesla 2, Tesla 3. So what Tesla you are using in the MRI, it depends on that one. Then patient movement. So if you are planning to demonstrate one rib cage. So patient is continuously taking breath in and out. हमारा may need 30 to 40 minutes. So we cannot ask patient to stop the breathing for 30 to 40 minutes. So images are continuously moving during the acquiring the images, so which we cannot avoid. For CT scan, it may be a matter of 30 seconds to 50 seconds. So we can ask the patient just hold the breath for a while. So that is possible in CT scan, but it is not that much compatible, and patient may not be stable properly. So he may have the fluctuating head or abdominal content. So that affects the image quality. Then calibration and other image settings, that also affects it. Coming to the radiological image quality, that is the resolution. Resolution determines the level of detail an image can show. There are two types of the resolution. One is the spatial and one is the contrast resolution. The spatial resolution means ability to distinguish between the two small structures which lies close to each other. While the contrast resolution is differentiate between the different types of the tissue densities. For example, suppose two dots are there, and these two dots after the detector, if it displayed in the merged things like this one, these two dots are not detected as the separate things, then the resolution is less. If these two dots which are lying adjacent to each other, if they are detected as a two separate dots, then the image quality is very good. Another problem is the noise. What is exactly noise? In olden days, we used to see our televisions, black and white televisions. So many black and white gray dots used to come in that one, grainy appearance. So we used to say that lot of blurring or the images are not clear, like that one. Here, all the radiological images mostly we are seeing, they are the gray, white and black. That scale, gray to black scale, or you can say white to black scale. Scale of the gray is there. So when we take the image, we capture the image, there is signal to noise ratio is there. Signal means that it should be real. For example, bone. Bone should be white in color. So if your bone is white in the bone, if the bone is continuous in that one, if you are getting one black dot, that means it is the noise. Suppose, for example, the CSF is white, should be black in color. In that black CSF, here you just see the CSF, it should be black. In that one, you are getting some gray dots. So this is the noise. So we have to find out the ratio, the signal noise ratio. If the signal noise ratio is higher, that means the quality of image is more and you can easily identify the structures. So your final 3D model output depends on the signal noise ratio. So this optimization of the image parameter is required to get the good quality images like exposure time. Exposure time, usually we will see our photographers. The photographers will do the manual setting in the digital cameras and then they will capture very nice images. Actually, they are adjusting the exposure time, ISO and many other parameters. Like that one here also in the radiological images, we have to adjust the exposure time, tube current, voltage, and patient dose, contrast, dose of the contrast, or we can change the contrast. That lot of factors are there. So that need to be adjusted to get the good resolution. Even after the this one, we can go for the manual reduction or noise reduction. It means we can process the images, these radiological images before creation of the 3D model. We will have pre-processing. So before getting the final result. For example, this noise reduction is very commonly done to get a clear picture. Suppose these are the images. This is one image and this is the another image. In the image which on the left side, this image, it is the original image which is having some lot of granular appearance, while the image on the right side is having less granular appearance because here the filter is applied. So this is called as the pre-processing of the image. So Gaussian filter is commonly applied filter to reduce the noise from the image. Here in this radiograph, we can see this is the arch of aorta and a descending thoracic aorta. So this descending thoracic aorta is becomes more clearly visible after applying the Gaussian filter. So this is called pre-processing. Another is, suppose for example, you are working on hematoma or you are working on the tumor, you want to find out the dimensions of the tumor. That time you have to pre-process the radiological images using the histogram equalization. Here you can see the histogram equalization. There are two images, top image and a bottom image. In the top image, there is not clearly visible. The tumor size is smaller. But once we have done this histogram equalization, you can clearly define the tumor, how it looks or what is the size of that one. So this comes under the pre-processing of radiological images. There is also another contrast stretching, sharpening, lot of things are there. I'm not going in detail. I want to show the journey, how the CT scan or MRI images, we can create the 3D model from them. Then artifact removal, this also becomes essential because during the radiological X-ray, there may be some artifact, patient is wearing clothes or he may be wearing some earrings or some other things may be there, and he may have some other prosthesis. So that can be removed in the pre-processing of the radiological images so that we can have the accurate diagnosis. Then there is also next step is called as the image registration. So what is image registration? Actually, scout image is taken. What is scout image? When we start the CT scanning or MRI scanning, we take one raw file or rapid scan of the patient where we will get the first image. And after that one, if patient moves little bit, it will not affect. After this one, we will align all the images. So that particular alignment, image registration, maybe big vector for as an anatomist, I can say only alignment. So all the images which are moved here and there, they will be aligned properly in one direction and we can see it properly. So here we can see that the CTs can see one image is on the downside and another image is on bottom side. Once you give command to the software, it will align the images properly. So that is called as the image registration. So image registration, how we can do? There is a rigid registration, non-rigid registrations are there. There are a lot of techniques also, that is the landmark based method or intensity based method. We have to select the command for the computer. So this variability of the patient position is the main issue in the image registration. See, if the patient is moving in one axis, that is the x-axis or y-axis, so the images can be aligned very easily. But if the patient is moving in 2 dimensions or the 3 dimensions, like the head is straight, instead of that one, he is tilting the head. So the next slice will not be proper in that same segments actually. So that alignments can be done using the software, using the image registration. So that is very important. So image registration, or you can say the alignment. After that one, the next step is the segmentation technique. In the segmentation techniques, it involves the partitioning of the images into the meaningful region. Complicated term. Simple thing, you have taken the CT scan, you want to see only the vertebrae. So that is the segmentation. Other things will be removed. So identify the region of interest. This identification or selection of region of interest depends on you. So what you want, manually you can select the bone density and it will show only the bones. It will remove all other soft tissue. Or you just select the trachea or the gas in the pipe of the respiratory system and it will show only the respiratory passage. You select the blood vessel, it will show only the blood vessel. So that is the manual thresholding, region growing. These are the different segmentation techniques. For example, suppose someone is working on the knee joint. So knee joint is surrounded by the skin, muscles, soft tissues. So we don't want to do that one. We want only directly to go and see only the knee joint bones, that is the tibia and fibula or femur, whatever. So that bones, it will, one simple command will remove everything and it will give you the final output, how the femur and tibia is there and how the knee joint is there. So such a things are called as the segmentation. So these are the various segmentation techniques. Don't worry, I am not going in detail explaining this one. So there are different, you just be aware that segmentation is possible. Segmentation means selection of a particular things. Maybe age selection, maybe watershed algorithm, clustering method. So there are different methods. Graph-based segmentation is there like that. So now the main thing is volume rendering. So this volume rendering is the main 3D representation. from 2D image slicer or volumetric data, allowing for the detailed inspection of the internal structures without physically sectioning the object. This is only our target. We want to see the internal structure of the organ, external surface of the organ without dissecting the human body. So it is possible due to this volume rendering. In olden days, what used to happen? They used to see only the section. Now the software will create the lung, only the lung, without the bones, using the CT scan. So that process is called as the volume rendering. So for the volume rendering, it utilizes the voxel based data. These are the data represented in the 3D grids, and that is converted into the volume, that is the lung volume. So source data it utilizes. For example, these are the 3 CT scan images and which can be converted into the model or this computer-based program. We just have to give the command volume rendering. So it will convert it, it will show which is the bone, which is the muscle, which is the lung, and different types, which is the blood vessel. It will analyze on its own. They are programmed like this one, and we can get the final images like this one. It is possible. This is called as the volume rendering. So this volume rendering, there are different techniques like a direct volume rendering, maximum intensity projection, and minimum intensity projection. So initially we have seen that is the direct volume rendering. So completely, it will create the model. It will show all the tissues. But we want specifically to show the bones, or we want to see only the bronchial tree. So bones are having the maximum intensity in the CT scan, and the air which is having the lowest intensity. So here rendering techniques are there, maximum intensity projection and minimum intensity projection. So when we give the command for MIP, that is the maximum intensity projection, only bones or highly dense, which are having high density, that structures can be kept. Other structures will be removed and we can easily see the bones. Same things, minimum intensity projection, that means only the blood vessels, or you can see the bronchial tree can be visible. In this diagram, you can see just the bronchial tree is visible, and bones and other solid structures, it has been removed. Here, bones are visible and major contrast things, wherever contrast is injected, that is visible. So this is the difference of the rendering technique, maximum and minimum intensity. After that one, next is the 3D reconstruction algorithm. We are moving towards the model creation. So surface-based reconstruction. In the surface-based reconstruction means outer surface only. We will not go in details inside. I want to see only how the lung looks from the outside. So surface-based reconstruction. So for this one also, it utilizes the CT scan or MRI images and stages. I am not going in detail of that marching cube algorithm or marching cubes. That one is not required. So in the surface-based reconstruction body, that means outer surface, it will remove the cavities. So like that one, surface of the bone, surface of the intestine, surface of the liver. These are the techniques of surface-based reconstruction. So this is also possible using this CT scan images. Then volumetric reconstruction, I have already discussed. This volumetric reconstruction is having a little bit internal depth structures. That means internal structures based on the voxel data or based on our input data, we can go inside. For example, we can see outer surface of the liver, we can see the internal texture of the liver also, we can see the branching pattern of the vessel also, we can even see inside the vessels. So all these things are possible due to the volume-based reconstructions. So there are different softwares. What softwares actually? See, now take-home messages are there from this one. Suppose you have given one topic for your postgraduates, that 3D model creation using CT scan images. Do you think that radiologist will allow your PG to sit on the CT scan machine or MRI machine and he will allow to work? No, from there you have to save the DICOM images, and after bringing the DICOM images. Now, if you bring the DICOM images in your CD drive or hard disk, now you don't have access to their software, then you need another software for this 3D model creation. So it is available free of cost, 3D slicer, open source software for visualization and analysis of the medical images. So it supports the multiple imaging modalities. So you can utilize the various tools and things. And another software is Mimics. Then OCRX. So these are the different softwares which are available. Some are free, some are commercial. Like Mimics is the commercial software, 3D Slicer, OCRX Lite. It is the free available software for 3D model creation. Each have some advantages, some disadvantages. But yes, of course, if you retrieve the data of the DICOM images from CT scan, MRI or ultrasound, you can analyze them in your laboratory by sitting on your computer. You can utilize this software and you can analyze them. These are the another softwares also. So I will not go in that detail. Coming to the DICOM file format, I have told initially only the DICOM images are there in the packs. So from the CT scan machine or from the radiology department, you need this DICOM file format. So finally, you are going to create the 3D model, and 3D model is utilized for further analysis or further things. So when you convert this DICOM file format into STL, that is the stereolithography, STL file format, image format only. This is layered file format. It can be utilized for 3D printing also, STL file format. So this STL file format can be created using the DICOM file format for further processing. For example, this is the skull which has created, but it has not properly came out after the CT scan analysis. So we can smoothen that, and finally this DICOM images is converted to this 3D model, and this 3D model we will have some finishing touches, and after that one we will save this in the STL file format, and that STL file format can be utilized for the printing on 3D printer or for further analysis. So how to save these DICOM images? So these DICOM images can be exported as it is in your pen drive, but don't touch the pen drive. You can use the CDs actually for saving, so that virus issue will not be there. Then before processing, you have to denoise the images, so you will get the better result. So this MetaLab or many other free softwares are there which can just denoise this image. During denoise, you have to apply the Gaussian filter, and this Gaussian filter will remove most of the noise from the issue. So OCRX, mostly what 3D anatomy table we are seeing dissection for the dissection table, they are using this OCRX software. So OCRX software, it is having the DICOM compatibility. It can read MRI, CT scan, PET scans, PET CT, ultrasound, all these scanning images, it can read. It has two versions. One is the lighter version and one is the commercial version. So both the versions are there. Lighter version have limited type of the options which are available. Then after that one, it will process the image, and it will tell you the analysis. Finally, you can utilize that one for your research and educational purposes. Only drawback of OCRX I found, it is only compatible with the Mac operating system. It is not available for Linux or the Windows. So this OCRX is also doing the volume rendering. Why I want to tell this one? Because you cannot utilize the patient care services. CT scan machine, MRI machines are already engaged for patient care. That you cannot utilize. You need data which can be analyzed in your computer system. So this OCRX is useful for volume rendering. So here the CT scan images are there. There are some plugins we have to download. And after that one, we have to select the command for the 3D volume rendering. And after that command of the 3D volume rendering, it will convert it into the cube. So that cube also contains the air which is surrounding the lungs that can be removed easily using the crop tool, using the scissor tool. So here first step is the cropping is going on now. After that one, scissor tool, see this portion is selected and which is behind the lung, and we will apply the scissor tool, so that will be removed, and finally we will get a lung output like this one. So this is the outer surface where we can clearly see the markings on the surface. See the beauty of this one. We have the restriction of the cadavers. In the medical college, we may have hardly 20, 30, 50 cadavers. But you want the study of the lungs, fissures. You want to see just the fissures of the lungs in 1,000 patients. Definitely, your medical college will have at least 1,000 patient data in PAC system. So that CT scan images you can utilize for the reconstruction, and same like what gross anatomy study we were doing, we can do these studies using these models also. We can apply some fine color. So here they have applied red color actually, so red on white color. So it will look or it will mimic similar to the natural body colors. Then this another free software is the 3D slicer. This 3D slicer is this software can utilize artificial intelligence like lobe segmentation. Here it has constructed the lungs from your CT scan data, and that in that lungs we want to see where is the horizontal fissure, where is the oblique fissure, which is the superior, middle and the inferior lobe. So that lungs lobe also can be studied using this software. So 3D slicer, it needs time to get expertise, but if you are aware, of course, one software you can start and you can utilize the data to propose your further study. So you need not have to go and keep on dissecting the cadavers. I am telling again repeatedly, there is a limitation of the cadaver. See the beautiful model they have created here using this 3D slicer. Here we can see the superior lobe, inferior lobe and internal bronchial tree also. Then division, primary bronchus, secondary, tertiary bronchus also we can see. We can measure the angle of the division. So carina also we can see. So lot of things can be done using the available data. So main thing, before planning your study, you need input. So what you want to see exactly, on day one only you have to select. For example, you have T1 weighted or T2 Tesla 2 weighted MRI or flare MRI. Here there are little bit difference. I am not going in detail, only touching here. If you see the CSF T1 black color, CSF T2 white color, and again flare MRI, it is black in color. So like that one, gray matter, if you see here, grayish in color in T1, whitish or light gray color in T2 weighted, again light gray color in flare MRI. So white matter, so what you want to see exactly? You want to study the gray matter, you want to study the white matter, or you are focusing more towards the CSF ventricles and cavities. Based on that one, you need to select what type of the input radiological images you have to utilize. So once you have created the model, you have to go for, these are the models we have already that in this one you have created this model actually. So this model, once you have created this model, then you have to proceed further actually. So what you have to do, you have to go for post-processing. So post-processing means, see, noise. Initially only I told there is a lot of noise. So noise creates the bad things. It may create some artifact, it may create the unsharp images. So that can be removed using the post-processing of the models. So post-processing softwares are there like a Blender, Mesh Mixer, ZBrush. Some of them are free, some of them are paid version. So Blender is the comprehensive. Suppose you want to give color to particular parts, so that are also possible using ZBrush, Blender. So like that one, these are there. Suppose this one model we got for the radius bone, and I want to give some details because that details was not there due to the presence of noise in the CT scan images. See, CT scan images or MRI images, we cannot have everything like the dissected cadaver. But of course, for creating the further detailed model, we can use the sculpting tools like ZBrush. So this is also possible. After that one, there is a mesh mixture. This is also the sculpting software. For example, there is a noise. So outer surface of this girl they have created, and in this one, suppose on the surface there is a hole, because we have removed the noise, we have done the denoise. During that one, we may remove some important portion of the body also. So during that one, there will be a hole in the body, so that can be filled using the mesh mixer and other things. These are the final sections now. Applications of these 3D models: surgical planning, prosthesis and implant creation, medical education. Vast, it is a totally vast 3D model application. For example, there is a virtual reality simulators. This can be created using the data what we have obtained. So these are the surgical training platform. This body can be created using CT scan and MRI images, and we can ask the trainee to perform the surgery before he is going for the real surgery. Same patient model, we will utilize same patient model, and observer or training teacher, he will see that what steps he is doing. So we can say personalized medicine, because the tibia, length of the tibia will be different in all individuals. So how much he has to put burr hole, the thickness of the temple will be different in all individuals. So how much he have to do the hole. So that type of personalized training or the things can be done using this type of the things. Then similarly, this is the immersive touch technology. Here, the CT scan images are utilized to create the 3D model, and the person can perform the surgery or he can have some trial. So he will have the visual impression at what depth he will have the facial nerve, at what depth the parotid gland is there. So how much in depth he has to perform the surgery, everything he can assess before going for the surgery. So these are the applications of these 3D models. Then anatomy dissection tables, these are widely now in use in India and all over the world. So suppose if you are planning for some study in the future, so see, this is the 3D anatomy model which they have created using the data. See, fine details they have added. This much fine details we will not get it. So these are the one post-processing, like a ZBrush, Blender, Maya. These are the softwares where they have added lot of details. But the external surface, the base which is created, is from the CT scan or MRI images. Particularly, see, the ethical concern is, can we expose the living individual? No, we cannot expose the living individual to this much radiation. But of course, one cadaver we can utilize for this much exposure. So that cadaveric CT scan or MRI can be utilized for creation of the 3D models nicely. So coming to the 3D printing. So here the CT scan images are utilized for the creation of the vertebral 3D model. So this 3D model is created, and after that one, it can be given command for the print of this 3D model. So these are the things this 3D model is created. It will create that STL files I have told. So it will print layer by layer, and finally lot of things will be there which are supporting the main structures that can be removed in the post processing to get final model of this vertebral column. So finally we can get this vertebral column. So these are the utilization. So in the conclusion, I want to say the fusion of medical imaging and conceptual techniques is very important. Enhanced diagnostic accuracy and surgical planning using this 3D model is possible, and advancement in the personalized medicine is the future of this concept. So take home message is skill that can be acquired by the practice and reading. Read, think, do it, and keep on learning. There is no boundary of the anatomy. You can explore more things and keep on exploring. Thank you. Thank you so much.
The topic is open for discussion. Any question from audience or from the online?
Dr. Prof, ask your question.
Good morning, sir.
Good morning. Good morning.
Sir, as you explained it very well, can I know that is it very similar to the anatomy's table, or it is only a it is along with the anatomy's table we have to learn, or it is any similarity, sir?
It is a very good question, actually. That was only the concept for this presentation. See, the concept is anatomy table, how they have created the model. See, we have the software called Maya or Blender. We can create the entire human body, but it needs a huge time. I sit now, and if I am planned to create the entire human body directly without CT scan images, it will take at least 3 years for me. Well, I am not that much expert, but it will take at least 3 years. And they can create using the CT scan images hardly in 1 or 2 months or 6 months. So that much difference is there. So this anatomy table is created using this type of software, using CT scan, using MRI images of the same patient, complete body CT scan, complete body they have utilized for this scanning, and they have created the tables. So the concept is you can explore the career, and you can join, and you can be a part of that one. So that's why I want to make young generation aware of this. Thank you. Thank you.
Thank you, sir.
One question from my side. You have beautifully depicted how the data is to be procured from the radiology department, seeing all how the artifacts have to be removed before capturing an image, and how the data is being stored in either in the PACS repository, or how to retrieve that data. And with the help of the various softwares, you have shown that the volumetric rendering processes can be done, and it can be utilized in research process. So my question here is, as you have named some of the software such as D2P or 3D Slicer or Oryx or Mimics, there are certain limitations of each or the other software. This volumetric analysis can be done in the fully automated mode or semi-automated mode or totally manual mode also. So how does it affect the geometric statistical analysis when it is done using this data in different modes?
Thank you so much, sir, for the question. It is actually the relevant question, because we are planning for the research. So the question arises whether validation of the data, we can say validation of the data. Here, there are different modes. One is the manual mode for the selection. Segmentation, we have seen now, the selection of the region of interest. So that is the selection. So for example, artery we are selecting. So how much we should select the artery? So little bit bias will be generated, that is sure, because these are not original from the human body. These are the images, scanning images. So it cannot match 100% with the human body. But of course, it can give some idea, like angle. In the angle, there will be no variation. Some point variation will be there in the thickness, luminal diameter. Suppose artery luminal diameter we are measuring, so it may not match exactly with the living individual. Some variation will be there, definitely. I agree with that one. But still, it gives us one opportunity to see the course of the artery. It gives us the opportunity to see the fracture sites and to deal with them, artifacts, or such as in the previous session we have seen, there are some areas of the aneurysm. So where the aneurysm is located, correlational studies we can do. So fine measurement is the drawback of this study, that I agree, but up to a certain extent.
Sir, suppose we are doing the morphometric or the volumetric analysis of suppose the corpus callosum, suppose. So when it is being done, it can be done manual mode, semi-automated, or totally automated mode. Which one is better?
See, sir, I always prefer manual mode in this section, or semi-manual or semi-automatic, because what happens is the software cannot understand the human body fully. We have to control. They understand only what is gray, what is black, and what is white. These three colors only it understand. 0 to 255 scale. 0 is totally black and 255 is totally white. So they arranges everything between that one. And we have to select the corpus callosum based on that one by reducing the noise, by removing the artifact. So best is the let it select, and we have to keep the control for modification in our hand. So here the observer bias will be generated. So to remove that observer bias, you can have the second observer also. You have to train 2 people for this, and it can be done. So semi-manual or semi-automatic will be better.
Thank you, sir.
Thank you.
Good afternoon, Dr. Yogesh. Nice to see you again.
No,
This is Dr. Rashid Prasad.
Yes, I recognize the voice.
So nice.
nice to see you.
Very inspiring person you are. So from the talk you have given, it's a message to the budding anatomist. Don't think only teaching, as before Dr. Sunitha and Dr. Yogesh is saying, is only teaching is there. If you have a good radiological knowledge and about the techniques and everything, you can open also all the radiological instruments in your own institution, right? Am I right?
Yes, ma'am.
Okay, so this is there. So you have more and more. So anatomy is spread everywhere. Thank you, sir.
Yes, ma'am.
For the talk is wonderful. Listening to you. Okay.
Thank you, ma'am.
So we'll have the next speaker.
Thank you, sir, for the wonderful session. Now, the person for model making, they can pin you on the screen and share your screen.
Hello. Kindly on your camera, Dr. Manisha Rajanand Gaikwad for model presentation. Can you hear me or not? Let's proceed to the other session. Now I would like to invite Dr. Dilshad Anwar, a very talented final year PG of our department, to introduce our next guest speaker, Professor Dr. Ravi Kumar Satish Ravi sir.
I think sir have joined or not.
Good afternoon, sir.
A very warm good morning to all of you. I'm feeling honored and privileged in inviting a person who is not only a stalwart of anatomy, but a living legend, and who is a huge source of inspiration for many anatomists in India. So before inviting Dr. Kumar Satish Ravi sir, let me give you a brief journey of Dr. Ravi sir here. Dr. Ravi is a graduate of Sri Krishna Medical College and Hospital, Muzaffarpur, and pursued MD Anatomy from prestigious JIPMER, Pondicherry. He also did his PhD in cytogenetics from AIIMS Rishikesh. Sir has served as assistant professor and course director and head of anatomy at School of Medicine, Spartan Health Sciences, University of St. Lucia, North America. At present, sir is a head of the Department of Anatomy at AIIMS Gorakhpur. Sir has conferred with Best Teacher Award in 2018 and Best Professor of the Year Award in 2021. Sir has published around 109 papers in international and national journals, indexed with PubMed Scopus. Sir, thrice he has been conferred the Best Paper Presentation Award. Sir is a regular member of the American Association of Clinical Anatomists and the American Association for Anatomists. He is a life member of Soca, Anatomical Society of India, Indian Society of Human Genetics. He is also editor of the globally recognized book Snell's Clinical Neuroanatomy. He was joint editor and section editor of the Neuroanatomy and Genetics in 2020. He assumed the position of editor-in-chief of the National Journal of Clinical Anatomy. Because of his commendable job, he could get the journal indexed under Scopus within a short time. Sir is a regular NMC inspector, coordinator, and served as undergraduate, postgraduate, and PhD examiner. And list goes on. So now I would like to invite Dr. Ravi sir to please join us with this couplet. Nahi tera nasheman kasre sultani ki gumbat par. Nahi tera nasheman kasre sultani ki gumbat par. Tu shahi hai basera kar pahadon ki chatanon pe. Please welcome Dr. Ravi sir.
My screen is visible, sir. Am I audible?
Yes, sir. Yes.
So good afternoon, one and all. Thank you so much for the wonderful introduction. I do not deserve that much. The way you introduced me, I'm really humbled and honored to listen to those words. Respected seniors, my colleagues, and beloved juniors. Today, I feel blessed and honored to be invited on this platform by Dr. Gauri Shankar Jha and the team of DMCH. I feel blessed. Why? Because I am a graduate from Sri Krishna Medical College, Muzaffarpur, just nearby Darbhanga. And indeed, I feel really honored that DMCH team has invited me to speak on this topic. Emerging imaging methods, their application in anatomy teaching and research. Let me tell you one thing, that I am not an imaging expert or something like that, but as an anatomist, when I was told about this topic, this CME, I thought, what are the imaging methods we can incorporate in our this anatomy teaching and training? And accordingly, just I have tried to put up in front of, I will be putting in front of you those imaging methods which we can incorporate in our teaching and training. And apart from that, we can also work or you can say involved in some of the research projects, these emerging imaging methods. Though if I say being an anatomist, I'm a advocate of this dissection method. I never say that a dissection can be replaced by any of the techniques, but yes, it must be substituted or we can complement, you say, because we see the different, just we can imagine about
लिंक उधर से लिंक
am I audible? Okay. Thank you, ma'am.
You're audible now, you can carry on.
Yes, ma'am. I'm trying to share my PPT. So is it visible? My screen is visible? Hello? My screen is visible?
Yes, sir, it is
Okay,
visible.
great. So that's what I was talking, that I'm a sole advocate of this dissection, cadaveric dissection. I wanted to say that what I feel that cadaveric dissection cannot be replaced by any, you say, the techniques, or you say, or any kind of, either you say anatomy, etc., or even the artificial cadaver, you say, like Cindever, right? So, but we must incorporate these modalities in teaching and training of our students. So I will be including so many images in my PowerPoint, but I wish to make it clear that these images do not belong to me. Now, before I will be talking under these headings, like the background, visualization, different imaging modalities, the application in teaching anatomy, and then finally I will be concluding my talk. Now, when you see this image over here, you can see that there is an elephant on this screen you can make out. With all due respect to the individuals with visual impairments, before I start my talk, I would like to share one story, a very short story, that consider that how someone who is blind, means who is not able to see or having this vision might have not be there, how they will perceive an elephant if they touch the different parts of elephant. So if you see over here, suppose a group of people with visual impairments once visited a zoo. Now, as they explored this elephant, the one person who touched this tail, if you can see over here, they concluded that this elephant resembles a rope. Now, if you see the another person over here, right, if the person who is touching the body of the elephant, if you say, right, person, if you see over here, who is sitting on the top of the elephant, right, they touched this ear and they thought, hello, am I audible? Hello?
Yes, you are audible. Dr. Ravi, you are audible.
That person who touched the this ear of the elephant, right, they thought that they are holding a kind of fan, that is the folding fan, you can say. There is another individual, if you see, who touched the trunk, they described that the elephant is like a tube. So what I wanted to say over here, that if you see the different individuals, when those who are not able to see this body, means elephant, looking at the different parts of the elephant, they are making that this is not an elephant, but they are touching a tube, or they are touching a rope, or they are touching a fan, you can say, right? So this is the problem if they are not able to visualize the object. So what I wanted to say, that this story highlights the importance of the visualization, you can say, which helps in fully understanding the shape, you say, or the nature of the object. So when we talk about the medical science, or particularly when we talk about the anatomy, this visualization is crucial for grasping the subject and its practical application. So with this background, we will be discussing today the imaging techniques that enhances the teaching, you say, or the learning of anatomy. Now, when we see over here, when we understand the diversity or the way the students perceive and learn anatomy, because that is very crucial. So when we hear the name of an object, like when we hear the name of an object, like if we say the heart, so it's natural that when we hear the word heart, we picture a heart rather than thinking about its spelling. So this tendency reflects our brains, that inclination to process, or you say the remember the objects in more visual, or you say the dimensional manner, rather than what you concentrate on the letter or the words. And better, we should imagine the visuals. So that is my concern over here. So in other words, we can say that anatomy is a fundamental subject that deals with the structures, and you say the structure details of the human value in their anatomical knowledge as much as, and if not, that anatomists themselves, they can tell that the different parts of the individual, what they see, they observe, and then only they can learn better rather than just going through the textbook. What I wanted to say, that visualization is comprehensively, whether through, you say, the direct observation or through various techniques, that is the imaging techniques. Now, when we see over here the visualization, since ages, we can say that we advocate, just now I said that the cadavers are the best tool to learn the anatomy. So anatomy of the, you say, the human body is being studied with the and different structures of the human body, witnessing and understanding with the help of the dissection. So dissection is a you say the methodical way to cut the different structures or the tissue. So with the help of the dissection, we say that we can imagine, we can know the actual depth of a viscera or the organ, you say, even the texture, the color, or you say the consistency of the structure. But there are definitely the limitations of these dissections. Like when we are thinking about this or doing some interventional procedure or the process, then during those time, we will face the difficulties or the limitations. Like when we talk about the dissection, it provides the static views of anatomy. What I wanted to say that it doesn't capture you say the dynamic interactions in the living bodies during the various medical procedures, like endoscopy or whatever the procedures, the surgical procedures we are doing. That time we have those limitations. Apart from that, all of are facing the hazards of the formalin, because whatever the cadavers we stored, we embalm the body with the help of this chemical that is the formalin. And we know that when we are preserving this body in the embalming fluid or in the formalin, right, it possesses the different types of the health risk, you say, because we know very well that this formalin is a carcinogenic agent. Apart from that, it also causes some kind of irritations, or you say the dry eyes. Apart from that, it also has some respiratory problem, because when we stay in the dissection hall for the longer durations. And apart from that, as I said, that it is a carcinogenic agent, so we have the chances of having the cancer. So these are the various hazards of the you say the embalming the body in the formalin. Apart from that, there are another limitations, as Dr. Yogesh had mentioned also, that we are facing the shortage of the cadavers. In many of the medical colleges, we see that they don't have even a single medical this cadaver. Recently, I visited one of the medical colleges. There, we didn't find even a single cadaver. So because of this shortage of cadavers also, we need to think the other aspects also, that how we can teach or train the students where we don't have the cadaver. Basically, after this COVID-19, we say this pandemic, we are having more scarcity of the cadavers, we can say. Apart from that, another limitations when we see, that is about the present generation. When we were attending the classes, rarely we used to see that anyone having this iPad or the tablet in the lecture theater. But nowadays, when you enter into the lecture theater, I will say that more than 80 or the 90% students, they will be having the iPad in their hands. They will not have the textbook or anything like that. Even the notebooks they will not be having, and they will be using even to note anything in the iPads. So the present generation, what I wanted to say, that they are very much fond of this you say the technology, right? And these modern learners or the students, when we say that they prefer this digital resources and simulations over the traditional, you say, the dissection method, and these are potentially affecting the effectiveness of the anatomical education. Apart from that, what I said previously, and then apart from that, the decreasing number of the teachers, because already all of you know that NMC has reduced the number of faculty in not only in anatomy but in other departments also. Apart from that, when you see the PG students, hardly you will find that PGs are joining in this field, anatomy, right? In most of the medical colleges, even if the institutions like INI, institutions of national importance, AIIMS and other, you say, the PGs, like when we say AIIMS Rishikesh or the Gorakhpur, the two institutions where I worked recently, no PGs are joining. So there are scarcity of the, you say, the number of teachers, the decreasing number of teachers. So these are the various limitations which are compelling us to move through the towards the technology, we can say. Now, the question arises, apart from these dissections, the cadaveric dissection, what are the other substitutes? So we can see over here, the plastination is another method by which we can teach or train the students. Apart from that, what I was discussing and I will be discussing over here, that is the various imaging modalities. Then apart from that, we have the syndever, that is the artificial cadavers. And Apart from that, we have the VR or AR, that is virtual or the augmented reality, etc. And then just now we discussed about the anatomy and etc. The different technologies are there which can help in teaching and training the students of the modern generation because of the various limitations, what we say. So when before we go into the details, or you say the delve imaging techniques, it's better to review how the traditional methods are used in teaching anatomy. When we talk about this imaging modalities, we have the diagnostic or the therapeutic uses are there. So these are non-invasive techniques or the approaches by which we create visual representations of the internal organs of the human body, you say, and tissues of the human body, which will help in teaching and training of the students. So these, if you see, whatever the modalities are there, what we used to teach, in even nowadays we are teaching, like we are using X-rays, ultrasound, CT, then MRI, the nuclear medicine. So these are the various modalities. My screen is visible? Hello?
Yes, sir. Yes.
So we will be discussing all these modalities one by one, but let's briefly discuss about the traditional way how we used to teach. So the very first thing which we can see over here is the X-ray. Now, when we see these X-rays, these are form of the electromagnetic radiations. We know very well, but still for the younger generation, I would like to highlight these things. So these electromagnetic radiations are used to create the images of the internal tissues, you say, or the bones over here, you can see in the images, and the different organs on the film or the digital media, you say. And these X-rays, if you see it passes through the body and they are captured by you say an X-ray detector will be there on the opposite side, and this will result the shadow which will be casted by the various structures which are present in the body. So this over here, you can see this way we used to teach radiological anatomy. Over here in this image, you can see that bones, the muscles over here, you can see when the X-ray passes through bones, it blocks the radiation and the bones will appear white in color. Similarly, if you see over here, the muscles, the fluids, the fats, these will pass some radiation through that and it will appear gray. Similarly, when you see over here, these are the bones. If there is a discontinuity in the bone, or what I wanted to say, if there is a fracture in the bone, right, then the radiation will pass completely through that, the fractured part, and it will appear black. So you can make out that there is a discontinuity in the bone or there is a fracture of the bone. Now, these are the various applications in anatomy. So it is also used to examine the various aspects of the anatomical structures, you say, such as the joints, you say, or the cavity, or you can say the integrity of the vertebral column, the structures of the bones, the hollow organs. All these you can make out. These are the various applications in the anatomy, and these can be compared with the discontinuity, or you say the altered anatomy, where just now I said when there is a fracture or the discontinuity of the bone can be compared with the normal structure, the normal bones. Coming to the ultrasound, when we see over here, when we see ultrasonography, this uses high frequency acoustic waves, and this way it generates the images of the internal structures that includes the various organs, you can say, like we can see the liver, uterus, the prostate, and even the blood vessels. So what I wanted to say that during this ultrasound procedure, a device is there. It has been discussed in detail in the morning session, I guess, that there will be a device which is called as the transducer, and that will convert this electrical energy into the sound waves, right? And which are then transmitted into the body's tissues. So what I wanted to say that these are non-invasive methods, and this uses the low energy radiation, but limited for certain organs only. Coming to the next, if you see this, that there are different forms of the ultrasound also waves, you can say, like you can see over here, there can be the endoscopic ultrasound, there can be Doppler ultrasound. And apart from Doppler, we can say the Doppler, the echocardiography. And even when we see this Doppler, it can be duplex or the triplex ultrasound is there, which uses primarily for the vascular studies to basically assess the blood flow and detect the abnormalities if there is the blood vessels. Now the question arises, what do you mean by this duplex or the triplex ultrasound? So when we see this triplex, it is an extension of the duplex ultrasound only. In the duplex ultrasound, we have this brightness mode and the Doppler mode. When we talk about the triplex, this Doppler, it will include this color Doppler also. So we will see in the coming slides all these the different forms. So over here in the morning, you have seen this Doppler, right? So over here in this image, you can see that this is a non-invasive technique and it can be used to visualize, you can say the different valves, or you say the blood vessels. Over here in the image, you can see there is a femoral artery, and over here, the blue color structures you can make out, this is the deep femoral vein. Similarly, over here in this image, you can see left ventricle or the left atrium. So with the help of the color Doppler, you can see the different blood vessels as well. The next, if you can see over here, that is the computed tomography, or otherwise we call it as the CT scan, right? So when we talk about this CT scan, it refers to the computerized X-ray. We have seen the digital, the general X-ray, and over here in the CT scan also we use the same ray, that is the X-ray. So this refers to this computerized X-ray imaging technique where a narrow X-ray beam is directed at the body, and there will be a rapid rotation will be there around the body. And this process, what will happen? It will generate the signal that the machines, or you say the computer process, to create the cross-sectional images over here you can see. And these cross-sectional images are known as the slices. This generates the cross-sectional images, otherwise it is called as the slices. And when you see this tomographic images will be there, this will offer the more detailed information what we have seen in the X-rays. Because when we see over here, these slices can be viewed individually, or even the multiple successive slices, if we see over here, can be digitally, you can say, stacked to produce a 3D image of the patient. And that will facilitate in the easy identification of both, either you say the basic structure or even some of the abnormalities or there, or you say the potential tumors or the tissues that can be made make out easily by this CT scan you say. Now, if you see over here, there is another, that is the contrast CT, which also can be used in teaching and training of the students in the anatomy. So when we see this contrast CT, all these X-ray imaging, whatever we are discussing, like X-ray or you say the CT, these, if you see over here, Dr. Yogesh was also discussing the same, that over here, you can see the dense structures, even if it is related to the bones over here, you can see, which can be easily visible with soft tissues also with the help of the, you say the CT scan. And this will vary in their ability to absorb these X-rays, and this will appear either the faint or it will be difficult to distinguish. So to address these things, these contrast agents will be incorporated, and these have been developed to enhance the visibility on the X-ray or the CT scan. Over here you can see with the help of the contrast, you can see the blood vessels as well. So these agents will contain substances like which will block these X-rays, and that will make you can say like these agents, you can say that maybe the iodine you say, or there are the different types of agents are there. So these will be used to highlight, you say, the blood vessels when examining this circulatory system or the blood vessels you say, and that will improve not only you can say the blood vessels, but it also helps in seeing the different you say esophagus, you say the different parts of the GIT or the stomach, or you say the GI tract. So all these can be seen very well with the help of the contrast CT by using the different types of contrast agents we say. Now, apart from this CT or the contrast CT, another imaging modality is, that is the MRI we say, otherwise it is known as the magnetic resonance imaging, right? So this again, this MRI or this magnetic resonance imaging is a non-invasive diagnostic tool, that provides, you say, the detailed images of nearly all, you say, the internal structures of the human body, you can say, like all the organs, you say, the bones, muscles, or the blood vessels. All this can be seen with the help of the MRI, you say. So these MRI scanners will generate the various images over here. You can see, like these will use the powerful magnet, or you say the radio waves, and without the use of you say the agents like I just now mentioned, the contrast agent like the ionizing radiation, unlike what we have seen in the X-ray. So with the help of this MRI, these images can be produced, which will be very crucial for the clinicians also to diagnose the different kind of the medical conditions, you say, and this will help in the proper, you say, the management or the treatment of the patients, you say. Now, apart from that, there are advanced forms of this MRI also, like we can see over here, the functional magnetic resonance imaging. So these recent advancements in the MRI technology has led to the new techniques, right? So if we see over here, this MRI are used to assess the blood flow through the various arteries, even in the brain, you can see over here, right? So these MRIs will be helpful in seeing the various blood vessels, you say the arteries, and that will help in identifying the various kinds of the aneurysm, you say, either you say the berry aneurysm or the cerebral aneurysm. That will be helpful in diagnosing the various, you say, the vascular malformations also. So what I was talking about this fMRI, that is also in this condition, if we say, there will be this, in case of the fMRI of the brain, it will focus the pinpoint, right? So there will be pinpoint specific regions of the brain, and that will be responsible for certain functions, like we say the speech, or you say the memory, etc. So these general areas, what I wanted to say, of the brain will be associated with such specific functions like speech or the memory, as I said, and this will allows for the precise or the pinpoint exact location, you say, and that can different from individual to individual. So this way, fMRI can be used to pinpoint the specific location to know about the various functions. Now, coming to the next modalities, what we can see over here is the nuclear medicine. So when we talk about this nuclear medicine, this technology, basically it is related, restricted, you say, to the for the treatment of the patients only. It has not incorporated in the teaching and training of the first year or the medical students, you say the MBBS also, even up to the final year. So this typically should be introduced from the very first year. In case of the nuclear medicine, what we see that it involves the small amounts of the radioactive material, and because of this radioactive material, it helps in production of the images of the different internal structures, and it helps also in detecting the various abnormalities, you say, like the different types of the tumors, you can say, or the different kinds of the infections will be we will be able to identify with the help of the nuclear medicine. So this is done with the help of the specially designed cameras, and that track the path of the, you say, the radioactive tracers. So what I advocate that this modality is also valuable for diagnosing and this monitoring the specific conditions that includes the cancer, or you say the heart disease, or even the different kinds of the thyroid disorders or the disease related to the, you say, the thyroid. Coming in continuation to that, if we see over here, the different types of, like we say SPECT, or we say the PET scan. So in case of this SPECT, if we say these images, it provides the 3D images by tracking the distribution of the radioactive tracers molecules which are introduced into the body. So what I wanted to say that it produces the 3D images by tracking the distribution of the various, you say, the radioactive tracer molecules which are introduced into the body. And because of that, the 3D images will be generated by the computer, and that will be from the numerous projection images which will be taken from the various angles around the body, you say. And this Well, basically the difference when you see between the SPECT and the PET, right? So the key difference between SPECT and the PET is the different types of the radio tracers which are used. When we talk about this PET scan, this uses the radiopharmaceuticals to create the 3D images. Whereas when we see this SPECT scans, it detects the gamma rays, whereas as I mentioned that the PET scan involves the radio tracers that emit the positrons. Now the question arises, when we see these positrons, right? So there is similarity between, you say, the positron or you say the electron. But the only difference, if you see, is that there is a mass difference. But what is that? That in case of the, if you say this, what I mentioned over here, that is the positron, the charge will be opposite of what we see in the electron. So this is the major difference, you say, between the PET or you say the SPECT. Now, apart from these, there are other types of also nuclear medicine, the various forms of the nuclear medicine over here. You can see that is the bone or the joint scan. Apart from that, the liver or spleen scan, the muga scan, renal scan, and the hepatobiliary scan. I'm not expert of that, so I will not be going into the details of that. But just what I wanted to say, that these modalities can be introduced in the first MBBS students, and that will offer the anatomical details in different dimensions, and that will definitely help in understanding the human body better. Now, apart from this nuclear medicine, when we see over here, this you can see the angiogram.
Hello.
So, question arises, what do you mean by this angiogram? So again, this angiogram is a diagnostic scan that basically visualizes this blood flow through the various arteries or the veins, you say, or even in the heart, you say. So what happens that when you see this angiogram, this visualizes the blood flow through these arteries, veins, or the blood. Using X-rays, what we have seen in the CT, that is the computed tomography, or even you say the magnetic resonance, that is the MRI we have seen over here. In case of these, we will say that MRA, that is the magnetic resonance angiography. So this will help in identifying the different blood vessels. So this procedure will involve injecting a contrast, right, dye into the bloodstream, and that will enhance the visibility of the blood vessels on the scan. So over here, if you see this,
Ravi, hello.
Yes,
excuse me. Your screen is not being shown.
Not visible, ma'am?
PPT is not being shown, sir. Yes, now it's seen. Now it can be seen. Thank you.
Is it okay?
It is okay now.
That when we talk about the dissection, this dissection will allow the students to see the structures by the naked eye with or you can touch the different visceras and all. But whereas when you talk about this angiography, it will provide you the details. Like when you are dissecting this brain, you can see the different blood vessels in the, you say, the circle of Willis. You can identify this anterior cerebral artery, or you say the anterior communicating artery, and even the posterior cerebral artery. But when you see the different central branches, right, like anteromedial or the anterolateral branches, it will be difficult to identify by the naked eyes. But with the help of this, you say, the angiography, you say, right, it will provide the insights into the fine branches of the blood vessels, and which are very much, I can say, essential for the, for the diagnosis, or you say the clinical practice, right? So integrating these imaging modality with the traditional methods of teaching will definitely enhance the knowledge and even the whatever the understanding we gain through the dissection, adding these modalities. So this is one of the modalities we can use while teaching or the training of the students. Similarly, over here, if you can see this cerebral angiogram, right? So this cerebral angiogram, it offers a detailed view of the brain's arterial network you can see over here. So this imaging technique will illustrate all the arterial tree of the brain, the finer structures you can make out over here in the cerebral angiogram. And this will definitely allow the comprehensive understanding of all the structure, or if there is any clinical condition or any abnormalities are there, like just now I mentioned, that is the aneurysm, anything, you will be able to make out through this cerebral angiogram. Another you can see is the contrast CT. So this imaging technique will provide clear and detailed view of the structures, you say, without the need of the invasive procedures. Over here, you can see that use of low dose contrast agent in the cerebral angiography produces high quality diagnostic images. So these modalities we can use in teaching and training the students. Apart from that, if you see what we discussed over here, that CT scan or the MRI we discussed, there is micro CT and the micro MRI. So these are the advanced versions of the CT scan and the MRI, and these micro CT and the micro MRI will provide extremely high resolution images. And because with the help of this micro CT and the micro MRI, when we see, right, in case of the small animal models, it is used in research involving, you say, the detailed anatomical studies in the small anatomical models, as mentioned over here, you can say. Apart from that, even when we are studying this bone micro architecture, this helps in detailed studies of giving this bone micro architecture and even the development. So the benefits of using this micro CT and the micro MRI are that it provides the detailed exploration of the anatomical structures. Over here you can see in the image, and it is the non-destructive imaging methods, so it can be used even for teaching, training the students. Apart from that, when we talk over here, the application in anatomy teaching, what I mentioned previously on the other speaker, they mentioned, because of the cadaver shortage, we must upgrade the recent technology, otherwise we will be far behind. Then these are the non-invasive techniques, so we can use these, and this will help in the future clinical application, as well as we should include this in our curriculum. So what I wanted to say, that it is very crucial to integrate these recent technologies into the curriculum from the very beginning, so that people will be relying not only on the outdated methods, but like you say the barium swallow, you say, or the barium meal, or you say the cholecystogram, but we should upgrade our knowledge and incorporate this technology, right? And that will definitely help the students with a modern understanding of anatomy, we can say, if we incorporate these methodology, the various methods in the curriculum from the very first year. Now, apart from that, another methodology, if you see over here, that is the optical coherence tomography, that is the OCT. This OCT, it uses light waves to take the cross-sectional pictures of the tissues. And we can use in anatomy for, you say, the microscopic resolutions, which will provide the images of tissues at a microscopic level, and which will be useful for studying the histological anatomy. Apart from that, even in the department of, you say, the eye, the ophthalmologist, they use this to study this eye anatomy, or they also involved in the research and education to visualize the retina and the cornea. So this offers the high resolution images, and this is definitely useful for studying the microanatomy of the tissues. Apart from that, if you see over here, this is the cryo-EM, that is the cryo-electron microscopy. So this involves the imaging samples at the cryogenic temperatures, and that provides the, you say, the near atomic resolution images. And this will definitely allow for the study of the macromolecular complexes and the cellular structures at very high resolution. So this can be used extensively in the virology to study the structures of the viruses, different viruses. And this can be helpful because the high resolution imaging will be there, and that will provide the very, you say, the easily available from the microscope and all. So apart from that, it also helps in understanding the biological processes at the molecular level. So this people are means I don't know that if in anywhere in the Department of Anatomy people are using or not, but through literature review, I thought that if they have some people, they have the infrastructure, they can think about all these modalities. Anatomies, a lot have been discussed. I think during this COVID-19, in many of the medical institutions, the people have started using these virtual dissection table, not only anatomists, but you say the sectra and all, they have started using. So even the National Medical Commission has recommended this anatomies. Dr. Yogesh has already discussed about this applications of this anatomies. Now, when we see this anatomies, what is the beauty that it not only provides only dissection, but it also provides the images, the CT, MRI images, even the patient data you can incorporate, you can study on that, and then you can have the histopathological images are there. So these are the various positive sides of the anatomies are there, but I will always advocate for the cadaveric dissection, and this anatomy or the sectra can be used, but we should not solely dependent on the anatomy. Now, what we discussed over here, that anatomies only we should use when we have the cadaver scarcity, right? You can see over here, these are the cost maintenance of the cadaver lab will be high when we see this lack of time and the shortage of the, in case of the shortage of the manpower, we can use this anatomies. Apart from that, if you see over here, when we have this anatomies in the Department of Anatomy, only one technician will serve the purpose. Whereas when we need to maintain this wet lab, we need to have 4 or 5 staff minimum to take out the cadaver and even for the embalming or the different things. So that will definitely help in case we have the shortage of manpower. Now coming to the next, that is the 3D printing and the computer-based technology. It has already been discussed in detail by the previous speaker, Dr. Yogesh. So I will not be going into the detail, but if you see over here, this cross sections of the various anatomical structure can also be obtained via this, you say, the computer-based software or the programs, that the various applications are there. And that is like AR, you say, that is the or augmented reality or the virtual reality, you say. These can be used in teaching and training the students. So over here, you can see the haptic technology Am I audible now?
Yes, sir. Yes, sir. Yes, sir.
So, because already it has been discussed about the augmented reality or the virtual reality, I will not discuss in detail about that. Now, just to conclude over here, if you can, I can summarize my presentation. So what I can say that this new imaging techniques have definitely revolutionized the teaching and the research of anatomy by offering the detailed, dynamic, or you say the interactive visualizations of the human body. And these advanced tools deepen our understanding, you say the foster new discoveries and enhance the educational outcomes, which establishing their essential role in, you say the contemporary medical science. And as technology progresses, these methods are, you say, can be expected to evolve further, which will provide even more precise and the insightful perspectives on the human anatomy. And over here, if you see the take-home message, so I can say that these emerging imaging methods are transforming anatomy, teaching, and research with their advanced capabilities, you can say, like when we talk about this enhanced visualization. So definitely the techniques like you say the MRI, CT, ultrasound, these provide the detailed images of the anatomical structures, while 3D reconstructions and you say the VR stimulations definitely offer these immersive learning experiences. When we talk about this educational impact, definitely these interactive tools like you say the VR or you say the 3D printing, this enables hands-on learning and it provides the better spatial understanding and safer practice without the use of the cadavers, we can say. So regarding this research advancement, I will say that these imaging technologies like you say the fMRI, you say PET and the cryo-EM, these reveal insights into the, you say, the physiological processes and the molecular structures, and definitely this will enhance the research and this will you say enable this cross-disciplinary research, you say, or the study. So apart from that, when we talk about this clinical applications, this detailed anatomical imaging will improve further in the, you say, the pre-surgical planning and the patient education. Even it will help in the diagnosis, you say, and the better treatment or the considerations. Because when we see the different medical colleges, either you say the state medical college or state government medical colleges or the private medical colleges, these medical colleges, they don't have that infrastructures, right? They don't have that much money because these equipments or these modalities costs too much because it have high cost. So definitely it will be difficult for them to purchase these equipments. You say either you say that anatomies, sectra, or even the artificial cadavers, it is quite difficult to buy because they don't have the money. So high costs, one of the limitations, you say the challenges is there. And apart from that, even we anatomists, we are not trained of these modalities, whatever we discussed about this imaging modalities. So even we need to be trained as an anatomist so that we can deliver to our students after we are well versed with this technology or the techniques or the imaging modalities what we discussed over here. And apart from that, even I can say there are some ethical concerns are also there in the research settings, and these poses certain challenges and the considerations you say in implementing these imaging modalities. But what I can say that where there is a will, there is a way. If we wish, we can definitely collaborate with the different institutions. Suppose if I don't have the electron microscope in my department or the institute, we can collaborate with the nearby institutions where, like, suppose if at AIIMS Gorakhpur electron microscope is not there, if at BHU is there, so we can have this student exchange program or the faculty exchange program, and then we can utilize those infrastructures which are there in the different institutions or the departments, we can say. So with these words, I sum up this presentation. I once again say that where there is a will, there is a way. We can incorporate if we wish to do that, right? So these recent imaging modalities significantly will have impact on the teaching of anatomy. Either you say the directly or you say indirectly. And we should use these. I advocate that even the Department of Anatomy should have the ultrasound in the department. Suppose some old ultrasound machines are there in the institutions. Those old ultrasound machines can be planted in the Department of Anatomy so that we can improve our research work with the help of these imaging methods. So with this, thank you so much. And I'm very happy to share with you all. Today, I'm introducing one of my latest textbook, the textbook of histology, which has been authored by Dr. Pushpa NB, my co-author. She's very talented, very dynamic. And with me, we both, this will be very, very helpful for the students because keeping the need of the students in the present scenario, how much time they have, keeping those things and what are the requirements are there, we have authored this textbook. So I would humbly request all of you to recommend this textbook. Thank you. Thank you so much.
Thank you, sir, for sharing your knowledge with us. Your insights are very informative and inspiring for all of us. Thank you, sir. Now, I request our chairpersons to ask questions.
Satish sir, hello. Hello. चलेगा क्या? Hello, hello. Kumar, Satish, Ravi. Thank you very much, Dr. Kumar, Satish, Ravi, for your nice presentation. Thank you.
Kindly complete the model. Yeah. Dr. Zeba, I think she also has a talk offline after the model.
They are waiting, ma'am.
All the participants on online mode who are presenting the model, they please come forward. All model participants should come forward with their models.
Tabassum, I would, Dr. Jha, I would request कि Zeba का talk हो जाए. She has some urgent work to do. तो वो जल्दी हो जाता. 5 मिनट का करवा दो या 10 मिनट जो भी है, whatever she has to spare. 15 minutes.
Now I would like to invite Dr. Zeba Alam from NMCH Patna to share her research work done on human adult tricuspid valve. Please welcome Dr. Zeba Alam. Please welcome Dr. Zeba.
Thank you, Dr. Sadasu. Respected Principal Sir, DMCH, respected HOD, Department of Anatomy, DMCH, organizing and co-organizing secretary,
of this conference, Dr. G.S. Jha and Dr. Archana, honorable judges of this session, and all the dignitaries of the dais, and my colleagues and juniors. Good afternoon to all of you. After this heartwarming and eye-opening sessions on radiological imaging and anatomical applications and the role of anatomy and how you have to combine it with the recent technologies for the benefit of the student, I'm here to take you one step further, where we combine the knowledge of anatomy with this radiological imaging technique for the benefit of mankind. So I'm going to present you this study regarding the investigation into the morphology and histology of the placenta in mothers with hypertension. So we know that pregnancy-induced hypertension is one of the leading causes of maternal mortality and the fetal demise in today's scenario, and in the backdates also. So PIH, or pregnancy-induced hypertension, as we all know as a doctor, that is defined by some authors as rise in systolic blood pressure above 140 millimeter of mercury and diastolic above 90 millimeter of mercury after 20 weeks of gestation. And some authors say that no, we are not going to indulge in absolute values. They rather take it as rise in 30 millimeter of mercury in systolic blood pressure and 15 millimeter of mercury in diastolic over and above the normal values before 20 weeks of gestation. So let's see what is the impact of this pregnancy-induced hypertension on the placental morphology and histology through this study. So we all know that the placental formation starts from the second week of gestation and is said to be completed by the 12th to 16th week of gestation. But the growth of placenta continues throughout pregnancy and the placenta is said to be mature by 34 weeks of pregnancy. So when we take the section of the placenta and see histologically, we find some things. And we know that it has 3 layers from inside to outside. It has the extraembryonic mesodermal tissue, which will give rise to the fetal blood vessels. Then it has a layer of cytotrophoblast and the syncytiotrophoblast. The role of the syncytiotrophoblast is that it is eating in nature, and it erodes the maternal blood vessels to help in getting the maternal blood collected in the lacunae so that the exchange of gaseous and other materials can take place through the placental barrier. And it is known as syncytium because the cellular boundaries, they vanish and they appear multinucleated, hence the name syncytium. So we all know that as anatomists. The syncytial nuclei are often, so when we look at the section, histological section, the syncytial nuclei are often aggregated to form multinucleated protrusions from the villus surface. These being known as syncytial knots. Now these are different from syncytial sprouts and syncytial buds. So before we move further, we have to know these words. Syncytial sprouts are present from the early stages. So important to note that they are present from the early stages of pregnancy and represent the initial stages in the development of lateral villi. Those that do not form villi tend to become pedunculated and are shed off in the maternal circulation. Syncytial buds are an invagination of trophoblast into the underlying stroma. But syncytial knots, in contrast, are very infrequently seen before the last 2 months of gestation, and thereafter they appear rapidly in rapidly increasing number and become unduly numerous in prolonged pregnancy. Now, in some areas of villi, the syncytium between the knots is anuclear and attenuated, and if such an area overlies a dilated fetal capillary, it may on light microscopy appear to fuse with the vessel wall to form what is known as the vasculo-syncytial membrane. Now, these are specialized zones of the trophoblast for the facilitation of gaseous transfer. Okay, so that was about a little detail about the histology of the placenta. Now, in the present study, we had studied 80 placenta, which we gathered from the Department of Obstetrics and Gynecology, Nalanda Medical College and Hospital. And these placentae were classified into two groups, the control and the experimental, 14 control and 14 experimental. The control group was free from diseases like diabetes and hypertension, and proper routine were classified after the proper routine examination during the ANC visits. And the experimental group comprised of pregnancy-induced hypertension, and these were collected immediately after normal delivery or cesarean section. So the inclusion criteria was this. So in the material and method, the help was taken from weighing machine, inch tape, magnifying glass, dissection instruments, and histological lab and reagents. So what were the parameters that were taken were the weight of the placenta, the volume of the placenta, the thickness of the placenta, the insertion of the umbilical cord was also taken into account, and histological section using HNE and Mason trichome was done. When we did these methods, so the diameter of the placenta was the placenta was collected in normal saline immediately after it was cut off, and the cord was cut off 10 centimeters away from the placental insertion. And after removing the blood clots, it was washed in the tap water, and it was inspected carefully for the fetal and the maternal surfaces. And the diameter was measured, the maximum diameter was measured using inch tape, and another diameter at 90 degrees to this maximum diameter, bisecting it was taken, and the mean of the diameter was taken. The volume of the placenta was taken by dipping it into a beaker full of water, and the fluid replacement was measured in the graduated cylinder marked in centimeters. So after going through all these, it was found that all these physical parameters, that is the diameter, volume, and thickness of the placenta was significantly decreased in cases of pregnancy-induced hypertension. Regarding the insertion of the cord, only one study reported that the insertion of cord was affected in PIH, but rest of the study did not. So maybe the insertion of the cord is a developmental structure, and it is related to the developmental statistics rather than PIH. And on the histological examination, histological slide dikhaiega please. On the histological examination, on HNE and Mason trichome, there was narrowing of the lumen of the arterioles and the perivascular thickening. Also, there was extravasation of RBC in the septal spaces. So depicting the effect of the hypoxic insult to the placental tissue during PIH. So why this study was carried out, already so many studies has been done on this topic. This was carried out to further support the other studies and collaborate with them, and also to come to the conclusion that this is not happening by chance, and irrespective of the region, race, or region and race, this PIH has this profound effect on the placenta. And also in today's scenario, it is necessary for the usage of color Doppler indices to be an integral part of the fetal well-being, so that This disease can have early diagnosis and therapeutic intervention to minimize the fetal demise and the maternal complications. Thank you.
Nice
Thank you, Dr.
presentation.
Zeba. Very informative session by you. Thank you. But please stay here for some time. I request Dr. Professor Rashmi ma'am to felicitate Dr. Zeba. Kindly come here, ma'am. All participants of model presentation, kindly come forward. We will start this session now. Thank you.
No, it is showing off.
लैपटॉप पे स्टार्ट स्पीकिंग
This is fetal circulation.
Have they asked?
Hello. Dr. Manisha. Hello, Dr. Manisha.
Yes.
Can you explain what you have done?
My PGs are presenting, madam, their models now.
Excuse me?
My postgraduate students are presenting their models.
Yes, I know you are a postgraduate. What have you presented? Could you explain your model?
Ma'am, good afternoon, ma'am. My name is Aarti. So I'm tutor in anatomy department, AIIMS Bhubaneswar. My model is fetal circulation.
Okay. ठीक है. So can you explain the circulation a little bit?
Yes, ma'am. So from left umbilical vein. So from left umbilical vein, so it is going to the liver.
Okay. ठीक.
So this is placenta. From left umbilical vein, it is going through liver. So it is bypassing through ductus venosus. and this is IVC. So this is right atrium, right atrium ventricle, left atrium, left ventricle. So from right atrium to left atrium, it goes through foramen ovale. So the blood, when it goes here, it bypasses through ductus arteriosus, then it goes to systemic circulation, then it comes back to placenta.
Okay. Now, what changes take place during birth or after, just immediately after some time after birth, which is different from the fetal circulation?
So ductus venosus changes into ligamentum venosus, foramen ovale closes, ductus arteriosus change into ligamentum arteriosus, obliterated umbilical vein will be there.
Okay, chalo. Thank you so much. Thank you.
Thank you, ma'am.
Next candidate.
My name is Aarti from Anatomy Department, AIIMS. Thank you, ma'am.
We've written you as Dr. Aarti.
Next participant.
Very good. It is present over here. I'm very glad to present. I'm Dr. Shivapriya, junior resident in Bhubaneswar. I'm going to demonstrate my model as showing the internal features of the right atrium of the heart. So when we see the internal features of the heart, we can divide it into rough part and the smooth part. So in the rough part, we can see the muscle ridges. Those are called pectinated. Moving towards the smooth part of the right atrium, where we can mainly see the fossa ovalis, which is surrounded by a rim called limbus fossa ovalis, and the veins will be opening into the right atrium, smooth part of the right atrium of the heart. They are in the superior aspect, it is opening up SPC. In the inferior aspect, it is opening up SPC. Along with that, the coronary sinus, the venous drainage of the heart will also get into the right atrium. So if we see as embryological aspect, why we have rough part and smooth part is the rough part of the right atrium is derived from the primitive atrium during embryological period, while the smooth part is derived by the right hand of the sinus venous, venous in the heart tube, which is going to form the future heart. And more towards the fossa ovalis and limbus fossa ovalis. Fossa ovalis is the embryological remnant of septum primum, whereas the limbus fossa ovalis is the embryological remnant of septum secundum. Moving towards the opening of IVC and coronary sinus, they will be surrounded by a wall. The wall of IVC is called aeration wall, whereas the wall of coronary sinus will be called as aeration. And also, smaller veins which should be draining the right atrium can also direct into the right atrium, which is called venous. And additionally, we can see the artery which is running between the right atrium and the right ventricle, right part of the atrioventricular group. The artery will be the right coronary artery, and the right atrium, right part of AV group will have the small cardiac vein. And these are all the structures we are seeing over here. This is SVC. This is arch of aorta with three main branches. And here, this is the IVC. This is about my model now. Thank you so much.
Thank you, Shiv Priya. You have very well explained the development of the right atrium, and you have also told about the arch of aorta. Can you explain how it is formed?
It is not. Chordate hiatus will be formed from the actually from the single arch artery. It will be formed from the left fourth single arch artery.
Okay, thank you.
Thank you.
It is not.
Next candidate.
Sir, myself, Dr. Karan Kumar, PG first year, Anatomy Department, AIIMS Bhubaneswar. Sir, myself, Dr. Karan Kumar, PG, Anatomy, AIIMS Bhubaneswar. And I painted the origin of the palmar and process muscles. And this is the palmar and process muscle. These are 4 in numbers. It is named from lateral to medial. First palmar and process muscles is one origin from the first metacarpal, and second from the second metacarpal, and third. The middle finger does not have the origin of palmar and process muscles, and the third palmar and process muscles originate from the fourth metacarpal, and the fourth arises from the fifth metacarpal bone. And I'm showing a little bit the joint also, carpal joints, wrist joint. This is radius bone, and this is the ulna bone, stolite process, the ulna bone, and this is scaphoid bone. This is scaphoid bone, trapezium, trapezoid, capitate, lunate, and the hamate bone, and this is triquetrium bone. The action of the palmar and process muscle is adduction of the finger, and along with the flexion at the metacarpal joint, and extension of the PIP and DIP also. And the nerve supply of the palmar and process muscle is by the deep branch of the ulnar. This is.
Dr. Sen, you're talking about you've told about the palmar penosis muscles. And what about their nerve supply? Have you shown their nerve supply also? Excuse me.
Nerve supply of the palmar process is by the deep branch of the ulnar.
But how they are supplied, from which side they are supplied, you should, I think, should have also drawn in that, because action of the muscle and the nerve supply is an important point in this aspect.
Pardon, ma'am, can you repeat the question? I have not heard properly.
Very nice painting done, and this is good, but थोड़ा सा उसमें हमें लगता है कि होना चाहिए, right? Thank you. Next candidate, please.
Next participant, model presentation of body painting.
Hello.
Yeah, hello, ma'am.
Who is presenting this?
Yes, ma'am. Good afternoon, ma'am. This is Kanishwaran, tutor from the Department of Anatomy, AIIMS Bhubaneswar. Hello, ma'am.
What have you done?
Ma'am, I did my atlanto-axial joint. So now I'm going to show that atlas separately, axis separately. So how it is going to articulate and forming the atlanto-axial joint. And like parts of the atlas as well as the axis, ma'am. So, and this is the atlas bone, and which is having the anterior tubercle here and posterior tubercle here, and this is the lateral masses of the atlas, and we are having the transverse ligament of the atlas, and this is the vertebral artery, the third part of the vertebral artery, and this is the superior articular facet, which is going to like articulate with the occipital condyle, and this is that foramen transversorium, and this is the attachment of rectus capitis anterior and lateralis, and this is that levator scapular attachment, and this is the rectus capitis posterior minor valve. And this is the where the axis is going to articulate here. And the same thing here, it is the axis. Now I'll show this is the dents are the entire process of the axis, and like this is the anterior articular facet for the atlas, and this is the superior articular facet for the axis, which is going to articulate with the atlas and going to form the atlantoaxial joint. And this is the foramen transversorium for the vertebral artery, and this is for the ligamentum flavum. Now I'm going to articulate and show you how it is going to articulate. And this is the way of articulating this atlas with the axis and forming the atlantoaxial joint. Now this is giving a movement for articulation for the no movement of the head and neck. So when you want to say no, it is going to articulate with this atlas and axis and forming the no movement. And it is having this three joint, ma'am. One is in the middle. So one is in the middle, which is going to form the this pivot joint with the dents with the anterior tubercle of atlas, and two lateral, that is a plain synovial joint, and the lateral aspect. So which is articulating with the facets of the same atlas and axis, and it is supplied by the second cervical now.
Hello, Dr. Kanesh.
Yes,
did you make these vertebrae? Have you made them, or you have just colored them, painted them?
No, ma'am. Yes, I have made it, ma'am. This is from the clay, ma'am. Shall I break it, ma'am?
You have made this vertebra.
See, this is a clay, ma'am. Simply I prepared with the, see, these are the ligaments which is I prepared, ma'am. This is a clay only, ma'am. Shall I break it?
So it's a nice, then it's good. It's nice presentation. It is almost looking like an original one. I thought you've just painted it.
Yes, ma'am.
Good work.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
Next candidate.
Any other participant of model presentation or body painting?
Good afternoon, respected faculties. This is a clay model on how the bronchial arches are developing. So initially we have...
Excuse me, just a minute.
We have two aortas. So ventral and dorsal portions. The ventral portions of the two aortas, they will join together to form this aortic sac.
Hello.
And the dorsal portions, these are joined to the ventral portion by numerous arches, aortic arches. So this is the first aortic arch. So I have shown the arches which disappear using the yellow color, and the ones which remain in adult life using this red color. So first aortic arch, for example, this is forming the maxillary artery. Then second aortic arch, it will disappear and will form hyoid and stapedial artery. However, the third aortic arch, on either side, it forms the common carotid artery as well as the internal carotid artery. And for the external carotid artery, the buds arise from these on top of these third aortic arch. Next, we have the fourth aortic arch. So on either side, it is a different development. On the left side, it forms the, on the right side, it forms the right subclavian artery. And on the left side, it is forming the arch of the aorta. And then fifth aortic arch, that usually disappears as soon as it is formed. And finally, we have the sixth aortic arch. So these form the pulmonary artery. And on the left side, the distal portion of the sixth arch, that will be connected to the aortic arch using this ductus arteriosus. This will disappear or it will become a remnant after birth, about 12 to 24 hours after birth. This physiological closure will happen, and so that is my presentation. Thank you.
Hello.
This is Dr. Sayan Biswas from
Excuse me.
AIIMS Bhubaneswar, Department of
I think
Anatomy.
Dr. Sayan Biswas has already presented. So who is this?
Ma'am, actually that was Dr. Karan Kumar who presented from this same account.
Okay. Okay, thank you.
Any other participant of model presentation or body painting? Kindly join.
Hello, thank you. I think we should close it now. I think there are no more participants.
So the model presentation and body painting is over. I would like to invite Mr. Abhishek Mandalji for highlighting few important points on 3D printing for medical and complex surgery. One more participant of model presentation.
Hello.
Here.
Good afternoon, everyone. I am Dr. Ankit Kumar, Department of Anatomy from AIIMS Bhubaneswar. Here I have a clay model of pancreas and its related structure showing their relation to each other. But I want to focus on pancreas and duodenum. As you can see, pancreas fits nicely into C-shaped duodenum. As we know, hand as foot teaching method is quite popular among medical students. So here I want to show.
Hello, Dr. Sayan. Are you Dr.
Yes.
Sayan or someone else?
I am Dr. Ankit.
Excuse me? What is your name?
Ankit Kumar.
So please tell your name because...
Okay, ma'am. I am Dr. Ankit Kumar from Department of Anatomy, AIIMS Bhubaneswar. First year PG. Here I have a clay model of pancreas and its related organs, and they are showing relation to each other. I mainly want to focus on pancreas and duodenum. This is pancreas and duodenum. As you can see, pancreas fits nicely into C-shaped duodenum. As we know, hand as foot teaching method is quite popular among medical students, and here I want to show how that same method can be applied to pancreas and duodenum. As you can see in this image, one hand can be formed to make pancreas. Here you can see this is tail, body, neck, head, and uncinate process. And other hand can be used to depict duodenum. This is first part of duodenum, second part of duodenum, and third part of duodenum. This method has proven quite relevant in this teaching, and all the studies have shown that hand can be used as an anatomical tool to depict different organs, and retention through this method is quite high. Thank you, ma'am. Thank you, ma'am.
So the model presentation session is over. Now I would like to invite Mr. Abhishek Mandalji for highlighting few important points on 3D printing for medical and complex surgery. Kindly come on the stage. Please welcome Abhishek Mandalji.
Yeah, good afternoon, everyone. Hope am I audible? Can you hear me? And thank you so much, ma'am, and thank you so much for all the respected faculty members of the college. And so, my name is Abhishek, and I am from a company called Adroitech Information Systems Private Limited. So we are basically a 32-year organization who are having expertise in the medical modeling solution. We represent a company, Israel-based company, that is named Stratasys. And this company is practically doing all the complex surgery and preparing all the 3D models that can be developed either from the MRI or the CT data. So out of that, some of the models that has already been there in the table, I'd like to request everyone, if you are interested, then you can come up and see the models. So we have our system installed in different AIIMS like AIIMS Delhi, Savita Dental College, as well as we have MGM, and recently we have done it with AIIMS Bhopal. And also I'd like to thank Dr. Panchal sir to let me introduce for such an exciting event. So now our head, Mr. Saksam Rastogi, who is the application head for the digital medical modeling solution, he will be giving a short presentation for the different case studies that has been developed with the help of this particular 3D printer. So over to you, Saksam. Just start the presentation. And if you have any queries, please feel free to ask me or Saksam.
चम्मच इसी से हो जाएगा ना? हाँ ठीक है कर। रुक नहीं रहा है पानी, लगातार हो रहा है बाबा। थोड़ा रुक जाता है। चलो नहीं रुकेगा। तो बरसात है ना, कैसे बताएगा बरसात का मौसम? ऐसे ही बताएगा, तब ना जाके धीरे धीरे ठंडा हो जाता है तो जाड़ा आ जाता है। ऐसे ही करते धीरे धीरे पूरा ठंडा हो जाएगा और जाड़ा आ जाएगा। जाड़ा का मौसम इसी तरह ना आता है। बारिश नहीं होगा तो ठंडा कैसे होगा मौसम। और बढ़िया से चला लो, 2-3 बार और चला लो। ऐसे ही करोगे तो क्या है, जो आलू भी है मोटा मोटा तो फूट जाएगा, वो तो टूट जाएगा। कपड़ा से पकड़ लो, पकड़ना है तो कपड़ा से भी पकड़ सकते हो। तो फिर छोटा चम्मच लेके भी कर सकते हो
Good
ना।
afternoon, everyone, all the faculty members and students. So we are from Adroitech and we are presenting here about the 3D printing application on the medical imaging and complex surgeries. So how 3D printing can be further used. So you have seen like from the examples like how what kind of softwares we can use to convert the CT scans, MRI scans into a 3D model. Now how those 3D models can be further utilized for pre-surgical planning, complex surgeries, and also for training educations and for the research works. So this technology which we are talking about today, which can help using the all these models which we have printed and presented today. So this is what we call the polyjet modeling or polyjet.
हाथ भिगा के चकला पोंछ लेना है ना।
World available where we can print the multi-materials and multicolor. So you can print the softer materials, you can print the rigid materials with the color formations, and those provides a very high fidelity models. That means you can print the biomechanical accurate models. It can replace the cadavers also when it comes to the teaching practices or even for the pre-surgical plannings. You can use all kind of tools. And when we talk about the workflow process, so you have seen like Dr. Yogesh has explained very beautifully how you can convert the CT MRI scans using different softwares like mimic softwares or oscillate softwares or even the 3D slicer softwares. So those softwares can be utilized to convert the CT MRI scans. And once you convert into a 3D model, now you can use that 3D model to 3D print. Okay, and that 3D printed models can be utilized like this. So this is a video. You can see how these models can be utilized. So you can mimic the all kind of the tissue material properties of any kind of the pathology models. You can mimic the bone mechanical accuracies also, so that you can do the all kind of the screw insertions, cutting, any kind of the process, suturing process also on these models. And it will give you the same kind of the feedbacks that you will feel on the real-time scenarios on the animal skin or the human skins. So you can see here, this is the 3D printed cardiac model. You can see here how the surgical plannings can be operated for training education purposes. So you can see this is the heart model. You can see how the actual tools can be used. So this is what we call the tissue materials, which gives the exact kind of the tissue behavior. And even the blood vessels model. So for the blockage or any kind of the blood vessels or blood flow systems or medical medicine testings also, these kind of the intravascular, accurate intravascular systems can be developed for the medical test devices and also preclinical testings for research work. You can see for the bone models also, every kind of the tools can be utilized when it comes to the implantation for screw modelings. You will get the same kind of the feedback, same kind of the tissue properties, bone properties, and also the bone marrow properties also you can mimic. So this kind of technology being utilized by lots of hospitals and medical device companies. So to give a few examples like AIIMS Delhi, AIIMS Bhopal, Akash Healthcare Hospital, MGM Aurangabad, Savitha Dental Hospital, these are some of the hospitals like, and even medical device companies like Baxter, Stryker, Medtronic, Oxygen Medical Devices, all these companies utilize this technology. You can see here that any kind of the tools, and this will not be like a clay model where
you cannot handle it, or you need a very, soft kind of the handling process. These are the high fidelity models where you can make a trial rooms also, and you can train the students, you can train the young professionals to how you can compete with the complex surgeries. So this is how the printing works. This is our printer, J750 digital anatomy printer. So all these innovations are being done because of these 4 materials that we present here. So first is the bone matrix material, which we can mimic the actual kind of the bone properties. You can also define in the softwares that if you want to make a denser, you want to make stiffer materials on bone. Gel matrix material is being utilized to make the intravascular models where you need very much good accuracy, very good strength, where you can utilize this for the blockage systems, for the cardiac processes, for neurology processes, all kind of complex surgeries. Tissue matrix materials, it mimics same kind of the tissue materials where you can print the skin. So we have some models here where you can experience the materials. It will feel like the skin, it will feel like the tissue material, the softness, the stiffness, it mimics everything. Then we have the radiometrics material. So in a past few years, lots of companies came that the 3D printing is not good and does not compete with the medical imaging analysis process. So now we have this material, radiometrics material, which is the only material in 3D printing which has a radiopaque properties. So this material is being developed specially for the medical imaging analysis or for the radiometrics materials, radiopaque accuracies, and it can reach the values of up to 1000 HU values. So from -50 to 1000 HU values can be achieved, and this can be operated through a software where you can define the values that you can mimic the same CT scan values into a 3D model. So this kind of properties can be utilized to make a lot of research work process where you can make a 3D model, you can do the medical test devices, you can do the preclinical testings and also surgical planning. So how it can be done? So like you can see some samples here. These samples are available on the table also. So this is the first stomach slice model. You can see this is a 3D printed model and this is the CT scan under the medical image process. This is for the foot model and this is for the blood vessel. So this is due to our software. So we have a software called digital anatomy software where we have all kinds of presets, whether you are painting a musculoskeletal, whether you are doing a bone materials, annulus, blood vessels, any kind of the bone, any kind of the pathology, any kind of human or animal pathology you are doing. So you can see here that these are the different models of hand with different material properties assigned. So you can change the values, you can do the research work, you can do the play around with the material properties and the input. So the applications that are associated with this 3D printing technology is like patient-specific models where you can do the pre-surgical plannings for training and education purposes for the young professionals coming and for the device testings or for the research works. So when it comes to the patient-specific models, so you can take the CT scans, MRI scans, and you can convert those into a 3D model, and you can make this with a very freedom of design. So there is no restrictions on the complexity, because when we talk about anatomy, there's lots of complexity comes into the picture for blood vessels, ligaments, tendons, and even for arteries also. But we have some of the very great models here where you can feel this experience. So this is the first example from the Akash Healthcare Hospital, who have 2 machines of this kind, and this is a one case study based on the progressive scoliosis dorsolumbar case, where this patient was suffering, and you can see this 3D printed model. So the left one is the pre-operative model, okay, which was in the real condition of the patient. The middle model is the first after the first surgery, okay, and the third one is after the third surgery, after the screw insertions. And how this process has been done? It has been done by printing a 3D model, specific patient-specific model, and doing the pre-surgical planning, then how those screw insertions being there and how those fitment can be done very precisely. And even after this also, these jigs and fixtures, okay, these fixtures where we used to plan the implant models, that can be 3D printed and that can be used during the operation. The second case study based on the training and education purposes. So this is the example from the AIIMS New Delhi from the neurosurgery department, and you can see here that the doctors here have developed a neurosurgical operative system which is called the NET OS, which is the patented model from there, and they have done a lot of research about using this technology. So these are some of the models which you can see here, whether it's an ENT process, whether it's a neurosurgery, cardiac surgery, or any kind of the complex surgeries. You can make these models for training and education purpose. So this is the video case study from CBMTI Singapore, and they are sharing their experiences from the neurosurgery department, that how this 3D printing, and you can see very great models here where we can define with different materials and also with different color formations. So these kind of the 3D printed models can be utilized to develop new kind of the medical strategies, where you can use new kind of the surgical tools and even the robotic process also. So if you want to teach the students how we can use the robotic technologies or other technologies during the operative system, so you need a real-time scenario where you can print such kind of the models and you can teach the students. They can get trained very well and they can also do the hands-on training method. So comparing to the AR and VR technologies where you can wear the devices and you can do the practices, but the real time scenario, the real feel of the tissue material or the real feel of how you're going to use this, any kind of the devices and tools during the operation. So those kind of feedbacks are still missing from AR and VR technologies, but that you can get from the 3D printed model very well. And third testings is on the device testings and R&D. So this is from the Jacobs Institute, USA. So this is an institute which develops a lots of intravascular models. You can see one of the models we do have here.
Very informative session. Thank you, Mr. Abhishek Mandal. Now I invite all the chairpersons to come on the stage for felicitation ceremony. Dr. Professor Vinod Kumar sir, kindly come here. Dr. Professor Rashmi Prasad ma'am, come on the stage. I request Dr. Abhijit Panchal sir to come on the stage, and Dr. G.S. Jha and Dr. Archana Gautam, please come on the stage. And our HOD, Dr. Professor S.K. Kern sir, come on the stage.
Now, first of all, we would like to felicitate all the three speakers, Dr. Sunitha BC ma'am, Dr. Yogesh Sontakke sir, and Dr. Kumar Satish Ravi sir. So I would request Dr. Paramjit Panchal sir to please felicitate Dr. Sunitha BC ma'am.
यस, आइए बताइए। हाँ, बताइए। नहीं, नहीं। हेलो। हाँ, नहीं तो HIV पॉजिटिव की बॉडी हम लोग लेते नहीं है। हाँ, ये आपके बड़प्पन है कि आप डोनेट करना चाहते हैं, बट हम लोग HIV बॉडी नहीं लेते हैं। ठीक है,
शायद हो सके कि हम लोग के लिए मेडिसिन रिसर्च या ट्रायल कुछ करना चाहें तो
नहीं नहीं बिल्कुल, मैं इसको आप क्या एज है पेशेंट का? 38। कोई बात नहीं, आप फॉर्म भर दीजिए, ठीक है, हमारे स्टाफ दे देंगे और जो होगा देखते हैं। बट यूजुअली हम लोग HIV पॉजिटिव बॉडी एक्सेप्ट नहीं करते। हाँ,
क्योंकि टीबी भी है,
टीबी
HIV का तो रोल है हमारे पास, मतलब मेडिसिन है नहीं। और टीबी के लिए घर में बच्चे हैं, सब लोग हैं, मतलब फैमिली मेंबर्स काफी ज्यादा हैं। तो क्या सर्वाइव कर सकते हैं, सर्वाइव करने लायक है या फिर इनका तो फिनिश किया जाए, कुछ इस टाइप की इंफॉर्मेशन चाहिए।
नहीं, वो तो देखिए कंसल्टेंट जो ट्रीटमेंट देते हैं वो वही बता पाएंगे।
तो सर
आपकी मदद कर देंगे, ठीक है? ठीक, नमस्कार। हो गया साइन? क्या बात बताओ, क्या बात है?
नहीं, वो अभी बॉडी में भी सेंटर।
अच्छा,
वो आए थे, वो बॉडी तो लेते नहीं।
नहीं बॉडी नहीं लेंगे HIV वाली, उसका कुछ मदद कर दो, पेशेंट दिखाने में है तो मनीष को भेज दो, ठीक है? वो ट्यूबरकुलोसिस भी है उस पेशेंट को, तो डॉक्टर सुबोध से दिखा सकते हैं, तो उसको नंबर में जो भी है मदद हो सकता है बोल दो, मनीष को कर देगा, ठीक है? गरीब है। और साइन करके आवाज नहीं आ रही है कुछ।
क्या बोलना है?
बोला खाना चोक हो रहा है।
चोक क्या हो रहा है? इरिटेशन हो रहा है।
मेरी हाँ तो खाना फंस रहा है, मेन सिम्टम ये होता है। इरिटेशन हो रहा है। स्पीकर पे लगाओ, स्पीकर पे लगाओ।
जाने
मतलब
नहीं जा
Voice is not audible, sir. डॉक्टर झा सर, आवाज नहीं आ रही है।
Sir, are we audible?
Yes, you are audible, ma'am.
Okay, sir.
Dr. Himansi, who came in the 40th hour and batted like the Surya Kumar. So she is the second best PG for helping me for the grand success of this all India level CME. So I would like to request Dr. Himansi to please come over here and request Dr. Rasmi ma'am to please felicitate Dr. Himansi Jha. Next, it is Archana Gautam, whom I trust most because whenever I think of any academic activity, she is the only one who always says, yes, sir, go ahead. And So I would like to felicitate Dr. Archana Gautam. I would request Dr. Paranjit Panchal sir to please felicitate Dr. Archana Gautam. Now finally, it's the time to declare the best among the best. He is the person who batted like the Rahul Dravid. He never tied up. Even on last night, he was here up to the 12 p.m. and early morning he was here from the 5 a.m. I have never seen such a dynamic PG, particularly in the anatomy department. So with a big round of applause, please welcome Dr. Pranay Barma, who is the best PG, I think, in my department. And request Binod sir to please felicitate Dr. Pranay Barma. Now, as the judges have decided for the model and the painting competitions, the Kaneshwar, who has made the Atlas vertebra from the AIIMS Bhubaneswar, who scored 8 marks and he stood first. Dr. Sayan Biswas have scored the 7.5 marks. He scored the second position. And Dr. Sib Priya, who have drawn the intercostal interosseous muscles. Interosseous नहीं है क्या? Structure of right atrium है. Internal structure of right atrium. क्या है? हाँ ठीक. So it is the Karan Kumar who have drawn the palmar dorsal interossei muscles. Scored the third rank. So all of you will get the prize money. I request all of you to please share your QR code on the anatomy imaging group, and after this session, immediately I will send you the prize money. Thank you. Now I request all the 4 participants of the welcome song to please come over here. Namuli.
The name for the welcome songers, Anju Kumari, Pari Kumari, Muskan Saha, and Shreya Sinha.
Now it's time for lucky draw. अब यही लोग यहाँ आए हैं, इन्हीं लोगों को बोलते हैं खींचने के लिए. सारी है हमारे पास, नहीं है. ठीक है, मंगा लेते हैं. मेरा ड्राइवर है ना, सही है मैडम. तो मंगाते हैं.
So the lucky winners are roll number 50, Namesh Aryan, roll number 80, Yuvraj Singh, सब लड़का ही. Roll number 53, Sonu Kumar. Come on the stage. You all come on the stage. Ankit Kumar, roll number 108. Pranav Kumar, roll number 35. You all come on the stage. ये भी गर्ल्स का नहीं है. ये तो चीटिंग हुआ, एक भी गर्ल्स का नहीं है. सारी गर्ल्स निकाली है.
देखो गर्ल्स लोग निकाली है, खाली बॉयज का निकला है, इसमें कुछ.
Now, the name behind this mega event, the man behind this is the Dr. G.S. Jha. As we proceed towards the end of the session, I wanted to extend my sincere gratitude to Dr. G.S. Jha sir for his exceptional efforts in organizing this CME. His meticulous planning and dedication are evident in every step of this event, ensuring a highly informative and smoothly run event. A big thank for his hard work and commitment in advancing our field of anatomy. At last but never the least, उनके लिए ये कहना बिल्कुल भी गलत ना होगा कि खुद को मनवाने का मुझको भी हुनर आता है. खुद को मनवाने का मुझको भी हुनर आता है. मैं वो कतरा हूँ, समंदर मेरे घर आता है. Please welcome Dr. G.S. Jha sir. And I request Dr. Professor Rashmi ma'am to kindly come here and felicitate the Dr. G.S. Jha sir.
It was a very enjoyable moment. Respected HOD, Dr. Karan sir, and organizing chairman, Dr. G.S. Jha, organizing secretary, Dr. Rashmi ma'am, Dr. Professor Rashmi ma'am, Dr. Karan sir, and organizing chairman, Dr. G.S. Jha, organizing secretary, Dr. G.S. Jha, organizing chairman, Dr. Professor Rashmi ma'am, Dr. Karan sir, and organizing secretary, Dr. G.S. Jha, organizing secretary, Dr. G.S. Jha, organizing chairman, Dr. Professor Rashmi ma'am, Dr. Karan sir, and organizing secretary, Dr. G.S. Jha, 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 organizing secretary, Dr. G.S. It was really enjoyable. I think all of you enjoyed it. I think I enjoyed it. Definitely it was. Thank you for calling us. And we hope to see much more of these activities in our whole state from all the places. You are now an example of how you organize and how you do things, so other people can follow, and I hope they get inspired by you. Thank you, Dr. Jha.
Thank you, ma'am.
I'm really very pleased to find the invitation from Dr. G.S. Jha. I'm really thankful to him. He has organized very nicely this CME, in which everybody participated, even online and offline, on a hybrid mode. I thank all of you, all the apart from Dr. G.S. Jha, the team of anatomy, all the teachers, professors, staff, and also the faculties of other faculties of medical college, even the principal, all the faculties and the students, all PG, everybody deserve thanks. Not only thanks, but Dr. Jha has provided at least some gift, some felicitation to everybody. I also thank all the participants and staff of the department and nicely organizing this CME. Thank you very much, Dr. Jha. And I also feel proud that he has invited me, though I am not a member of Soca. Still he has invited me to chair the session.
You must become, sir. You must become member of Soca.
You are the father of Soca, sir.
We will be blessed to have you, sir. We need your blessings.
So now finally, everyone waits for the vote of thanks, because after the vote of thanks, the program is over and you move towards the lunch or the break or the dinner. At the end of this vote of thanks, I will share you how you will get your certificate. So stay tuned till I bore you. So delivering a vote of thanks in a mega event like this, supported by so many individuals, is always a challenging task. I may miss few names, so I request those I miss to please forgive me. Firstly, I want to thank all the delegates, both offline and the online, but especially the online delegates who showed faith in us by participating in this first of its kind event in the history of Darbhanga Medical College, Department of Anatomy. We tried our best, but it is up to you to decide whether we met your expectation. We are humbled by the response from the esteemed anatomists across the India, starting from the Jammu Kashmir to the Kanyakumari. I don't think that even a single state have missed to participate in this mega event, whether it was professor, associate professor, assistant professor, tutors, PG, and they have shown their interest and registered themselves. Next, I thank all the speakers for sparing their valuable time and delivering the mesmerizing talks. It was due to you and our speakers, the banner of the Soca, that we received such an overwhelming response. Ab ki baar 400 par, and we achieved the ab ki baar 400 par, and the recent score is 444. In the meeting which was held in our department, when some of our colleagues asked me how many of you are expecting to will join the online platform, I told them it could be 100. Then they told me that we need to finance a lot because you will not get that much of money to organize this type of CME. Thanks God, we have got the overwhelming response from all across the country, because everyone knows the importance of the certificate, and that too the MCI accredited certificate. I also thank Principal Sir for his support. I also thank the first MBBS student 2K23 who are like my kids. From the bottom of my heart, may God bless you all to achieve the big success in your upcoming life. I thank all the members of my department, including our HOD sir, for allowing me to organize such mega event, because earlier it was not possible to organize such a type of event without taking so much of the pressure, and you have allowed me to conduct this CME in a very smooth way. I thank you, sir, from my core of my heart. All the PGs, all the staffs, but few names deserve a special mentions. Dr. Archana Gautam, my fellow anatomist, who supported from me from the day one when I decided to organize the CME and added maximum number of esteemed anatomists in the Anatomy WhatsApp group. Professor Dr. Seema Tabassum, who took on the responsibility of the Master of Ceremony with enthusiasm. Dr. Anitesh, who responded positively. Dr. Pitrais, who take the responsibility of the UG students. Dr. Himansi, who helped us immensely. And Dr. Pai, the best PG of this event, without whom it would not be possible to organize this event. I also thank Dr. Yogesh Sontakke sir for his prompt approval and support. It was he who helped me not only about the date of the CME, the theme of the CME, and he also convinced Sunitha ma'am to come and deliver her talk. I thank Professor Dr. M. Kumar sir for his humanity and the prompt registration. I salute you, sir. Really, you are a great person. May God bless you. Long live, sir. You are really I am think of any individual like you, particularly in the anatomy department. I have seen such humble person in my life. They were businessmen, but really I salute you, sir. You are such a great person. Dr. M. Kumar sir, the Secretary of the Soca, for allowing us to organize the CME under the agencies of Soca, and the meticulous editing browser and the certificate. Dr. Sunitha BC ma'am for sparing her busy schedule. Professor Rasmi ma'am, the Secretary of the BIHAR and Jharkhand, for her support. Dr. Binod sir, Dr. Ranjit, Dr. Paramjit Panchal sir for blessing us, provide their presence. I would like to thank Dr. Kumar Satish Ravi sir, whom we are really proud of because he is a Bihari and he is raising the flag of the Bihari all across not only in India but abroad also. I would like to congratulate you, sir, for the release of your histology book, which have been released just one day before. Now, we also thanks the media person, Manoj ji, the in charge of the auditorium, but at last, the most important person of this event is Mr. Vikas Bhagat. He is a dynamic person. I was not knowing him few days back, but without his support, this online platform could have been collapsed. So I really thank you, Mr. Vikas Bhagat ji, and hope we will work together in the coming time. If I missed anyone, please forgive me. Finally, शुक्रिया तेरे आने से रौनक तो बढ़ी, वरना ये महफिले जज्बात अधूरी रह जाती. Thank you. Now, I will share a link on the Anatimaging group that is called the feedback form. You will have to fill the feedback form. After filling that feedback form, after some time, you will get on your email ID the mail. Certify, you will get the mail that will be certified and you will receive your certificate. Now there is a question, only we have got the 3 speakers recognized by the Soca, Dr. Sunitha BC ma'am, Dr. Yogesh Sontakke sir, and Dr. Kumar Satish Ravi sir. So the topic of the only 3 speakers have been in that feedback form, and only those 3 speakers will get the participation come the speaker certificate. Now for my PGs, those who have presented the poster presentation, you are requested to send only the name of that topic on my personal WhatsApp. I will try to provide you the same type of certificate. If not possible, I will provide you the offline certificate. All the 4 students of the first year who came here for the welcome song, you will also get a certificate, and that certificate, if not possible, you just send your name on my personal WhatsApp number. I will provide you the offline certificate. Hope you enjoyed a lot. For any thought coming, it is upon me, and for any good thing, it is my department. Long live anatomy department. Jai Hind. Okay. Satish sir, कुछ बोलना चाहते हैं? हाँ ठीक है. Okay. Satish sir, over to you.
Yeah, thank you so much, Gaurashankar Jha sir. Honorable Head of the Department, Dr. Karan sir, Senior Most Faculty, Dr. Binod sir, Dr. Rashmi madam, and all the senior faculty members, delegates across the country, my colleague, Associate Secretary, Dr. Padamjit Panchal of Society of Clinical Anatomists. I thank each and every speaker, Dr. Yogesh and Dr. Sunitha madam, for accepting the invitations to be as a guest speaker under the banner of Society of Clinical Anatomists. I thank all the delegates for participating in this CME, which was for the first time, I think it is being organized in Bihar, any academic activity under the banner of Society of Clinical Anatomists. And for this, I am really grateful to Dr. G.S. Jha sir and his team for approaching the Society of Clinical Anatomists and under the banner of Society of Clinical Anatomists, organizing the first academic activity in Bihar. I have a very soft corner for Bihar because I have been trained in that state, and whatever I am today, I owe to that state. So previously also we inquired that you should host one conference of Society of Clinical Anatomists, but that time nobody was willing to host this conference. But I'm happy that Dr. G.S. Jha sir has taken this initiative and organized this CME, and not only the CME, even the competition to encourage the medical students, the younger generation. That was a great initiative, and for this also I congratulate the team of DMCH for organizing this academic event and the competition, you say. So Soca, on the behalf of the President of the Society of Clinical Anatomists, Professor M. Kumar sir, on the behalf of General Secretary, Dr. Muthu Kumar Vel sir, and on the behalf of our Treasurer of the Society, Dr. Pushpa NB, I am grateful to each one of you for participating wholeheartedly in this academic event. And I'm really grateful to all the team members of DMCH who has made this CME a grand success. And I'm also grateful to Dr. Padamjit Panchal, who has accepted our proposal of President and General Secretary to represent Society of Clinical Anatomists in that CME as an Associate Secretary. So thank you, each one of you, for making this academic event a grand success. And if any mistakes are there from the Society, on behalf of the Society, I apologize from each one of you. Thank you. Thank you so much.
Now the session is over. आप लोगों को खाना मिल गया? और खाना है? अगर खाना है तो मेरे साथ चल सकते हो डिपार्टमेंट। जो सभी लोग